Yeah.
I don't blame you. All right, your, looks like it's recording. Okay, seems like you're okay now. Okay.
Thank you.
All right, you're welcome.
Okay.
Yeah.
Okay, so components of the system. So we have a neuron, we have a ganglia, which message enter here. They excite the neuron and then the message exits. You have afferent versus efferent review. So an afferent is going to be your farthest, it's going to be your away, which is your sensory. Efferent is from your CNS to your periphery, which would be your motor. Okay, motor means movement. Okay, conduction of an impulse, you have a resting potential, action potential, depolarization, and repolarization. So we're going to go over all of that. So the neuron is the cellular component of the nervous system and is composed of a cell, body, and neural processes. A nerve is a bundle of neural processes outside the central nervous system and in the peripheral nervous system. A synapse is the junction between two neurons or between a neuron and an effector organ where the neural impulses are transmitted. This is just review. In order to function, most tissue structures and organs have innervation, a supply of nerves to the body part. Innervation, something is innervated by something. Remember we talked about it before? Your parotid gland is innervated by such and such. Okay. A nerve allows information to be carried to and from the brain, which is the central information center. An accumulation of neuron cell bodies outside the CNS is a ganglion. Plural is ganglia, such as a trigeminal ganglion, which we'll talk about. Okay, it's just like a bunch of nerves. So nerves are of two types. You have afferent and efferent. Afferent nerve, or your sensory nerve, carries information away from the periphery of your body to the brain or your spinal cord. What would be a periphery of my body? Like my fingertips or my leg, okay? If I bang my leg on the table, okay, my neurons are gonna send that information to my brain, right? That's a periphery. Periphery means surrounding or something around something, so something around your brain, right? Afferent nerves carry sensory information to the brain, such as taste, pain, and proprioception, which is the ability to sense body's movement or location. I can tell that my left leg is moving forward because of my sensory neurons, right? Why would that be important? Why would it be important to understand the afferent nerves? Toothache, right? So toothache, bitter tasting, not tasting at all, okay? An efferent nerve is a motor nerve that carries information away from the brain or spinal cord to the periphery of the body. So efferent nerves carry information to the muscles in order to activate them, often in response to information received by way of afferent nerves. Okay, I want to raise my arm up. My brain's telling my arm, go up. Right? Make sense? My brain is telling my muscles to activate for a motor movement. Okay? One motor neuron with its branching process may control hundreds of muscle fibers. As we learned last week, we have a lot of different, we learned myofibrils, myofilaments, etc. All those little fibers within a muscle. Okay? See how this class builds on each other? So to have the impulse cross the synapse to another cell requires the action of chemical agents or neurotransmitters. The neurotransmitters are discharged with the arrival of the action potential. So local anesthetic agents such as lidocaine are used in dentistry. They mimic inhibitory neurotransmitters by decreasing sensory neurons' ability to generate an action potential, thus producing localized anesthesia. It's blocking those neurons, okay? Which is why you don't feel any pain. You're getting your tooth drilled or extracted or whatever. Anesthesia is the loss of feeling or sensation resulting from a use of certain drugs or gases that serve as an inhibitory neurotransmitter. What do you mean by gases? Nitrous. Okay, anybody experience nitrous? Okay, kind of feels like you're drunk, or as my husband would say, had a couple wobbly pops. You been to Michigan? Forget. Wobbly pops, I guess, are alcoholic drinks that I just learned when I met my husband. Yeah, it's a kind of good name, right? It makes you a little wobbly. All right, one of the major divisions of the nervous system is your CNS, or your central nervous system. This includes only the brain and spinal cord. The system of membranes is the meninges, which has 3 layers. You have your dura mater, your arachnoid mater, and your pia mater. Okay, those are the different layers. The dura mater, which is just below the skull, also surrounds and supports the large venous channels, your dural sinuses, carrying blood from the brain toward the heart. The major divisions of the brain include the cerebrum, cerebellum, brainstem, and diencephalon. You need to know those and where they are. They're your sections of your brain. Cerebrum, cerebellum, your brainstem includes your medulla, pons, and midbrain. Your diencephalon is your thalamus and hypothalamus, and then your spinal cord. The cerebrum is the largest division of the brain and consists of 2 cerebral hemispheres. Okay. The cerebellum is the second largest division of the brain after the cerebrum. This is just a little snippet of what your brain functions are. So different areas normally control different functions. You have a frontal lobe, which would be your thought process, your speech, and your motor activity. Your parietal lobe, which would be where? Kind of where your parietal bones are, right? Sense of touch, association of many functions, and your temporal lobe is hearing, language, and memory. Then you have your occipital lobe for vision, which is why when you fall backwards and smack your head, you start going blacked out. The medulla is the closest to the spinal cord. The pons connects the medulla with the cerebellum and with the higher brain centers. And the midbrain includes relay stations for hearing, vision, and motor pathways. Okay, so make sure you know where all those are and what they're responsible for. Superior to the brainstem, the diencephalon primarily includes the thalamus and hypothalamus. Your thalamus serves as a central relay point for our incoming nerve impulses, whereas your hypothalamus regulates homeostasis, like your thirst, your hunger, your temperature, and your blood pressure. The other component of the CNS, your spinal cord, runs along the dorsal side of the body and links the brain to the rest of your body. The other major division of the nervous system is your PNS, your peripheral nervous system. It's composed of all the nerves stretching their pathways among the CNS and the receptors, muscles, and glands of the body. So your efferent division, you have somatic and autonomic. Of your autonomic, you have sympathetic and parasympathetic. We'll talk about all that. So your PNS is further divided into afferent nervous system or sensory nervous system, which carries information from your receptors to the brain. Okay, make sure we get that down. Or the spinal cord. And your efferent nervous system is also your motor nervous system, which carries information from the brain or spinal cord to the glands or the muscles. A nerve cell leading from the eye to the brain and carrying visual information is in part of afferent nervous system, that you're carrying it to the brain from the periphery, right? In contrast, the nerve cell leading from the brain to the muscles controlling the eye's movement is part of the efferent nervous system, because it's going from your brain to what it is that you want, what part of the body you want the action to carry out. Your somatic nervous system, your SNS, is the subdivision of your efferent system. It includes your nerves controlling the muscular system and external sensory receptors. So your SNS involves both receptors and effectors. So they receive the information and they also carry it out. Autonomic nervous system, ANS or ANS, is the other subdivision of the efferent division of your peripheral nervous system. This system operates without any conscious control as the caretaker of the body, such as what? What operates out of our control?
Breathing.
Breathing, what?
Just involuntary movement.
Any involuntary movement, your heart,
Heartbeat.
right? Autonomic fibers are efferent nerves and they always occur in two nerve chains. The first nerve carries autonomic fibers to the ganglion where they terminate near the cell bodies of the second nerve. That'll make more sense here shortly. Your sympathetic nervous system is involved in fight or flight responses, such as shutdown of salivary gland secretion. The parasympathetic nervous system is involved in rest or digest responses, such as the stimulation of the salivary glands. So make sure you know the difference between the two. Which one's fight or flight, which one's rest and digest. Parasympathetic fibers associated with the glands of the head and neck region are carried within various cranial nerves. The ganglia are located in the head, and therefore parasympathetic neurons in this region may be either preganglionic neurons, meaning before relaying the ganglion, or postganglionic neurons, meaning after relaying the ganglion. So your facial nerve is also known as your seventh cranial nerve, includes your greater petrosal and your chorda tympani. And your glossopharyngeal is known as your ninth cranial nerve, is your lesser petrosal, which is an example of one of your pants. This chart I would recommend you study. Okay, this is all the cranial nerves that are important in your PNS. All 12 paired cranial nerves are connected to the brain at its base and pass through the skull by way of fissures or foramina. You're going to learn every single one of these. You need to know every single one of these. Okay, and the foramina that they enter or exit out of. Okay. Some cranial nerves are either afferent or efferent, and others have both types. Okay, on that one sheet that I told you was kind of like a cheat sheet, it has some mnemonics on it. It'll tell you on there, afferent, efferent, or both. Okay, so like I said, take a look at that. That's a good study source for you. The cranial nerves are numbered according to their location in regards to the brain, going from the anterior of the brain to its posterior. Okay, so we're going to have cranial nerve 1, 2, 3, 4, 5, etc. So it's going to go forward to backward. Okay. Both Roman numerals and anatomic terms are used to designate the cranial nerve. So make sure you understand your Roman numerals from 1 to 12. Go beyond that. Okay. Cranial nerves are an important part of your PNS. All 12 paired cranial nerves are connected to the brain at its base and pass through the skull by way of foramina, which you've learned already from weeks 1 and 2. Now these cranial nerves are paired, meaning there's one on each side. All right, so keep that in mind. Just because I have a 7th cranial nerve on my right doesn't mean I don't have one on my left. Right, paired. All right, so starting off with number 1, first cranial nerve. Also known as your olfactory nerve, transmits smell from the nasal mucosa to the brain and thus functions as an afferent nerve because it's coming from the periphery going to the brain, right? My brain's not telling myself to smell roses, right? My nose is saying that I smell roses, that's sending it to my brain. Make sense? Okay. The nerve enters the skull through the perforations in the cribriform plate of your ethmoid bone to join the olfactory bulb in the brain. Okay, if you're having trouble remembering where your cribriform plate is and your ethmoid bone is, please go back to weeks 1 and 2. Okay, don't have time to go back to all that right now. Okay, your second cranial nerve is your optic nerve. Okay, you can imagine that's going to be somewhere around your eyeball. Okay, it transmits sight from your retina of your eye to the brain, thus functions as an afferent nerve. Your optic nerve enters the skull through the optic canal of your sphenoid bone on its way from the retina, which is number 33 on your skull. Your third cranial nerve, also known as your oculomotor, I gives you a hint, motor nerve, serves as an efferent nerve to some of the eye muscles that move the eyeball. Remember, your muscles are your efferent because it's a motor. Right? Efferent nerves are motor. Afferent is sensory. The oculomotor nerve lies in the lateral wall of your cavernous sinus and exits the skull through the superior orbital fissure on your sphenoid bone on its way to the orbit. It is responsible for pupillary, I can't ever say this word right, constriction and eye movements. So your eyes dilate and constrict with the different lights that come in. Also, if you've had too many lollipops, right? Okay. So this nerve allows that action to happen. Okay. The fourth cranial or trochlear nerve also serves as an efferent nerve for one eye muscle, as well as proprioception, similar to the oculomotor nerve, but without any parasympathetic fibers. Similar to the oculomotor nerve, the trochlear nerve runs in the lateral wall of your cavernous sinus and exits the skull through the superior orbital fissure of the sphenoid bone on its way to the orbit. Okay, so just because you have one foramina doesn't mean only one thing's going to go through it. Same thing with a fissure. Okay, you can have multiple items, especially when we get into talking about their venous system. Your fifth cranial or trigeminal nerve is probably one of your biggest ones that you're going to need to know for dentistry. Has both an afferent component for the muscles of mastication, or your chewing muscles, as well as some other cranial muscles, and afferent component for the teeth, tongue, oral cavity, as well as most of the skin of the face and head, which is why when we do local anesthesia, this nerve is targeting all those areas, and you get your skin numb, your lips go numb, your tongue goes numb, your teeth go numb, your gums, etc. All the good things we need, right? Because it has both afferent and efferent. On a side view of the skull, this tells you exactly where all of those nerve endings are coming from, okay? Let's take a look at this image in your book. So your trigeminal nerve is the largest cranial nerve, you need to know that, and has two roots, a sensory and motor. Cranial nerve number 5, trigeminal, largest. Your ophthalmic nerve is the first division of the nerve. Okay, still talking about our trigeminal, okay? It provides sensation of the upper face and the scalp. Your maxillary nerve is your second division of the nerve, and mandibular nerve, third division. It provides sensation to the middle and lower face. Your ophthalmic nerve, or your first division, enters through the superior orbital fissure. Your maxillary nerve is your second division and enters by way of your foramen rotunda. Your mandibular nerve is your third division and passes through the skull by the foramen ovale. It is your motor root. Make sure you know which one's your motor root. So tri meaning 3, geminal, has 3 branches. If you take 3 fingers, and you go like this, okay, you're going to have your mandibular division, which is number 3. You have your maxillary division, which is number 2. And what was your first division? Ophthalmic. Okay, so you remember it like this. I don't care if you do this during your exam, it happens all the time. Whatever you can do to make yourself remember. Right? The trigeminal nerve is the most significant cranial nerve to the dental professional because it innervates relevant tissues, structures, and organs of the head and the neck. Okay, so when we're looking at our image over here, okay, this is our trigeminal ganglion, which is that big area here where they all kind of meet together. And you have your mandibular nerve. We're going to talk about all the different branches. Mandibular nerve. Okay, you have your maxillary, it kind of goes out, almost like a sideways L. Okay, and then your ophthalmic. Your sixth cranial or abducens nerve, or abducent, however you want to say it, serves as an efferent nerve to one of the muscles that moves the eyeball, similar to the ocular motor and the trochlear. Similar to both of these cranial nerves, the abducens nerve exits the skull through the superior orbital fissure of your sphenoid bone on its way to the orbit. So this one runs through your cavernous sinus. Your cavernous sinus is here. You'll learn more about this when we get into the venous system. Okay. We kind of talked about this before. Why is this important? Remember? So if you get an infection here, or you anesthetize this area, or you get bacteria in this area, look how close it is to your brain. That's a good way to die, right? So you gotta be very careful. The seventh cranial or facial nerve carries both the efferent and afferent components. The nerve carries an efferent component to the muscles of facial expression. Your muscles of facial expression control what? Where do they all insert?
The skin.
The skin, right? And the posterior suprahyoid muscles, as well as for the preganglionic parasympathetic innervation of your lacrimal gland, which is what? What's your lacrimal gland? What does it do? Tears. Okay. And your submandibular and sublingual salivary glands. So, remember your lacrimal gland is out here. You have some lacrimal ducts here. However, your lacrimal sac is over towards your nose. Orient yourself. This is the medial aspect. Okay. This is where some of your tears will exit as well. Okay. And when your eyes are burning, your nose runs because all of that goop runs down your nasolacrimal duct and your lacrimal canal. Okay, so when you look at this is like the skin peeled back. You can kind of see all the different nerves. You can see some of the muscles are kind of chopped away so that you can actually see where these nerves are going. Okay, so your facial nerve, nerve 7. We're going to talk about your lingual nerve. We're going to kind of get into these a little bit more involved here. So don't get too caught up on this image just yet. I don't want to talk about this just yet. We're going to go more in depth of these nerves shortly. So your facial nerve leaves the cranial cavity by passing through the internal acoustic meatus at number 49 on your skull, which leads to the facial canal and inside your temporal bone. The facial nerve is another large one you need to know for local, but also for dentistry. So number 5, which was what? Trigeminal. And number 7, your facial. I'm not saying don't know the other ones, but I'm saying these are the 2 Mac Daddies of what we really need to make sure we do. Okay. So here's your facial nerve coming out. It has different branches. Your facial nerve exits the skull by way of a stylomastoid foramen on your temporal bone, number 24. This nerve is significant to dental professionals because it innervates relevant tissues of the head and neck, travels through the parotid salivary gland, which is again one of those spots that I said if you do your local anesthesia in the wrong spot, you're going to anesthetize the gland. That's going to be a problem. And we're not going through cheeks. Our needles. The 8th cranial or vestibulocochlear nerve serves as an afferent nerve for the hearing and balance. This nerve conveys signals from the inner ear to the brain. This gets affected when you have an ear infection. All of that infection puts pressure on the nerve, which then intervenes with the neurons that are being transmitted in there, and then you start losing your balance. The inner ear is located within the temporal bone. The nerve enters the cranial cavity through the internal acoustic meatus of your temporal bone. Your ninth cranial or your glossopharyngeal nerve carries an efferent component for the pharyngeal muscles, the stylopharyngeus muscle, and the preganglionic gland parasympathetic innervation for the parotid salivary gland. In addition, the nerve also carries an afferent component for the oral pharynx and for taste and general sensation from the base of the tongue, and thus is the afferent limb of your gag reflex. Our gag reflex is triggered a lot in dentistry with x-rays. We're trying to do oral hygiene instructions. You're trying to teach the patient maybe how to brush their tongue, right? Also, when we have to put the mirror back there. Sometimes you have to press against the tongue, get the tongue out of the way so that you can view on the posterior aspect, or check on the oral pharynx, check on those tonsils, see how everything's looking back there. Patients will gag. There are tips and tricks that you can use that will teach you that will help with that, because a lot of it is just up here. I have had patients that have a really hard time brushing their teeth because of their gag reflex. Sometimes it's worse at night, sometimes it's worse in the morning. And I know for me, I can't brush my tongue at night. I start gagging like crazy. I can do it in the morning, but I can't do it at night. So we're saying, I don't know, but it is what it is. Sometimes if you put salt on the tongue, that will help. Having the patient hold their arm out, wiggle their fingers, hold their leg up, wiggle their toes, move their ankle around. There's all different tips and tricks that we can help you guys to be able to get your x-rays, to be able to work on the patient, etc. Okay. So your glossopharyngeal nerve passes through the skull by way of the jugular foramen, which is number 20, between your occipital and your temporal bones. After supplying the ear, the parasympathetic fibers leave the skull through your foramen ovale, which is number 45 of your sphenoid, as a lesser petrosal nerve, which innervates the parotid salivary gland. I'm going to break these all down. This is basically just telling you what each nerve is, okay? So I know this is a lot right now, but we're going to break each nerve down. Inferior branches of the glossopharyngeal nerve supply the carotid artery, oral pharynx, and base of the tongue, which is your afferent component, as well as your stylopharyngeus muscle. Your glossopharyngeal nerve is significant to dental professionals because it innervates relevant tissues of your head and your neck, again, for local anesthesia. Your 10th cranial or vagus nerve carries a large efferent component for the muscles of the soft palate. Efferent was what?
What was that?
Motor. Okay. Why does the soft palate need a motor nerve? When you swallow, right? It's also with your pharynx and your larynx for parasympathetic fibers. To many organs in the thorax. Where's your thorax? Your chest, right? And abdomen, including the thymus gland, heart, and stomach. The nerve carries smaller afferent component for a small amount of skin around the ear and taste sensation for your epiglottis. Your vagus nerve passes through the skull by way of your jugular foramen, number 20, between the occipital and temporal bones. Your 11th cranial or accessory nerve functions as an efferent nerve for the trapezius and SCF. Remember, efferent is for muscles because it's motor, okay? As well as muscles of the soft palate and pharynx. The accessory nerve exits the skull through the jugular foramen, number 20, between the occipital and temporal bones. The accessory nerve exits through number 20. I just said that this nerve is significant to dental professionals because it innervates relevant tissues of your head and neck. 12th cranial or hypoglossal nerve functions as an efferent nerve for both the intrinsic and extrinsic muscles of the tongue. The nerve exits the skull through the hypoglossal canal, which is number 50, in the occipital bone. It's important to us because it innervates the tongue. Right. Flew through that one because that one was basically just a breakdown of which nerve goes with what's afferent and efferent, or what's both. Okay. We're going to start breaking down into really talking about each individual one here shortly. Right. So part 2. Oh, wait, there's more. Trigeminal nerve. Like I said, this is one of the MAC daddies that we really need to make sure that we know for dentistry. Okay, you must have a thorough understanding of this nerve. Each trigeminal nerve is a short nerve trunk composed of 2 closely adapted roots. Anterior to the trigeminal ganglion, remember the ganglion is kind of right here, which is where they all kind of meet. All the branches meet together. It's a meeting place. Okay. The sensory root arises from 3 nerves or divisions that pass into the skull by way of 3 different fissures or foramina in your sphenoid bone. You need to know which foramina or fissures each one of these branches goes through. Okay. Important to note that the commonly used term V1 for division 1, V2 for division 2, V3 for division 3. The V stands for number 5. So your trigeminal 5 division 2 would be V2. Make sense? Okay. One more time. So you have your trigeminal nerve. Trigeminal nerve is nerve number 5, which is your V. Okay, that V means 5. Okay. And then there's 3 divisions, 1, 2, and 3. So trigeminal nerve division 1 will be V1. Got it? Next. Correct. Sorry? Ophthalmic, yes. And it goes just in that order from top to bottom. Ophthalmic, maxillary, mandibular. Okay, that's simply shorthand notation for these nerves or divisions of the 5th cranial or trigeminal nerve, since B is Roman numeral for 5. So make sure you understand that and know that, because you'll see that on exams. You'll also see that on boards. You also see that if you take your local anesthesia board. Okay, it's not required, but a lot of you would be a good idea to do. That'll be this time next year. All right. The ophthalmic nerve and maxillary nerve of the sensory root carry only afferent nerves. What was afferent nerves? Sensory. Okay. The ophthalmic nerve or division, which would be division what? 1, enters through the superior orbital fissure. Bless you. The maxillary nerve or division enters by way of your foramen rotunda. In contrast, the mandibular nerve of the sensory root runs together with the motor root and thus carries both afferent and efferent. Why would we think that? Because maybe this is the only movable bone in our body. So if you remember that, motor, you need some motor movement. Motor neurons to help move the jaw. Okay. Your motor root of the trigeminal nerve supplies the efferent nerves for the muscles of mastication. Well, it needs to supply those muscles of mastication, because without it, your jaw's not going to know to go like this, chomp, 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 chomp on your food. Right? It's telling the muscles to activate. If you don't have those nerves, or you have damage to those nerves, you cannot have the muscles activate, so you cannot have your jaw move up and down. Or side to side, or whatever it is you need to do. Okay? It exits the skull at the foramen ovale of your sphenoid bone and then travels with the mandibular nerve of your sensory root of the trigeminal nerve. The ophthalmic division provides sensation to the upper face and scalp. The maxillary and mandibular nerves or divisions provide sensation to the middle and lower face, just as it's separated when you do this. Okay. So this would be my middle and my lower, which would be division 2 and 3, your maxillary and mandibular. Okay, my upper division or my upper part of my face is going to be your ophthalmic, which would be division 1. Okay. Your first division, V1, as it's notated, of your sensory root is your ophthalmic nerve. This smallest division serves as an afferent nerve for the conjunctiva, cornea, eyeball, orbit, forehead, and ethmoidal and frontal sinuses, plus part of the dura mater and parts of the nasal cavity and nose. So basically everything that's in the upper 1/3 of your face. Okay. The ophthalmic nerve arises from 3 major nerves: your frontal, lacrimal, and nasociliary nerves. What do I mean by it arises from? Comes from. Okay. When you're looking here, you have your frontal nerve, okay, coming off the ganglia here, okay. Coming down here is going to supply the frontal part of the head. Your nasociliary nerve, if you follow this, okay, actually goes through the eyeball down towards the nose, okay. This is your trigeminal ganglia here. This branch is going to be branch division 1, your ophthalmic. This branch is going to be division 2, your maxillary. This branch will be division 3, your mandibular. Your frontal nerve is an afferent nerve located in the orbit and is composed of a merger of the supraorbital nerve from the forehead and anterior scalp and the supratrochlear nerve from the bridge of the nose and the medial parts of the upper eyelid and forehead. So if we follow this along, here's your supratrochlear and supraorbital. Kind of tells you where it is, above the eye. Okay, so nerves going above the eye. Okay, and if you see right here, those nerves come together on this main nerve of your frontal nerve, which then comes together from your ophthalmic nerve. So when you're studying these nerves, you might want to study how it goes. Trace the nerve, where does it branch to find this nerve and this nerve? Okay, well then what branches from this nerve off? Okay, you'll kind of have an idea after the end of all these lectures today of what exactly which nerves to study. Okay, there's certain ones I'm not going to ask you. Okay. I'm not going to ask you internal nasal nerve and all that business. Okay. The lacrimal nerve serves as an afferent nerve for the lateral part of the upper eyelid, conjunctiva, and lacrimal gland. Also delivers postganglionic parasympathetic nerves that produce lacrimal fluid or your tears. So we have our lacrimal gland, our lacrimal nerve going into and through our gland here. Okay, if you follow this down, it's coming off of our division 1 ophthalmic nerve of our trigeminal nerve. Okay. Several afferent nerve branches converge to form the nasociliary nerve. These branches include the infratrochlear nerve from the skin of your medial part of your eyelids and the side of the nose. Ciliary nerves to and from the eyeball, and anterior ethmoidal nerve and posterior ethmoidal nerve from the nasal cavity and perinasal sinuses. So basically, I want you to know from this whole slide right here, your nasociliary nerve. Okay, your nasociliary nerve is a branch off of your ophthalmic nerve, your division 1 of your trigeminal. And it is an afferent nerve. That's all you need to know.
We don't want you to know. It's inside.
The second division from your sensory root of your trigeminal nerve is your maxillary nerve, which is set between the other 2 divisions, both in size and location. We look here. Here's our ganglion. our ophthalmic nerve, which then branches into our supraorbital and our frontal, our lacrimal, or our ciliary. Okay, now this branch down here we're going to talk about is our maxillary. That's going to also branch off, and you can see how it's starting to feed the teeth. Okay, so we're going to talk about all of these. The afferent nerve branches of the maxillary nerve carry sensory information for the maxilla and its overlying skin, oral mucosa, maxillary sinuses, nasal cavity, palate, nasopharynx, and part of your dura mater. When you do an anesthesia block here, or you get a patient anesthetized here, it's going to anesthetize the skin, it's going to anesthetize the oral tissues, it's going to anesthetize the tooth. Okay. The maxillary nerve is a nerve trunk formed in the pterygopalatine fossa by the convergence of many nerves. The largest contributor is the infraorbital nerve. Tributaries of the infraorbital nerve or maxillary nerve trunk include your zygomatic on the anterior, the middle and posterior superior alveolar, the greater and lesser palatine, and your nasopalatine nerves. You're going to need to know all of those. Okay, so this is basically a skull from a side view. Okay, so your infraorbital nerve, what foramen is this? Infraorbital foramen. Remember I said that if you target too high, you're going to anesthetize the eyeball, right? Because you can see there's branches coming up towards the orbit. Okay. Anterior superior alveolar. If you follow this down, you see it's going to branch off and anesthetize teeth. Anterior superior alveolar nerve block is actually an anesthesia site. Anytime that you see alveolar in a nerve, it's going to actually anesthetize the tooth. Okay, that's a key thing to memorize. Okay, anterior being towards the front, superior being maxillary. Okay. You also have your middle superior alveolar nerve coming off of your maxillary branch, coming down to then anesthetize the premolars, as well as sometimes the mesiobuccal root of number 3 to 14, that first molar there. Okay, so that's going to anesthetize the tooth and the tissues because it's got the word alveolar in it, right? Okay. We also have our posterior superior alveolar nerve coming off of our maxillary division 2 of our trigeminal nerve. Follow this down, and those branches come to your molars. Okay. This is a nice flow chart. So of your maxillary nerve, you have different branches off of it. You have your zygomatic nerve, your infraorbital nerve, your posterior superior alveolar, greater and lesser palatine, and your nasopalatine. Okay. Of your zygomatic nerve, you have your zygomaticofacial and zygomaticotemporal. Of your infraorbital, you have your anterior superior, middle superior. Okay, and then you don't have any branches off of these because these supply directly to the teeth. Okay, so I would study this flow chart. A large ganglion, the pterygopalatine ganglion, lies just inferior to the maxillary nerve within the pterygopalatine fossa. So here is a little itty bitty compared to your trigeminal. Remember I said trigeminal is one of the Mac Daddies, right? So here's your pterygopalatine ganglion lying in that fossa. The zygomatic nerve is an afferent nerve composed of the merger of your zygomaticofacial nerve and your zygomaticotemporal nerve in the orbit. So your zygomaticofacial can go right along where your zygomatic bone is. Okay, that's why it hurts if you get hit right in the cheekbone. Zygomaticotemporal is going to be a small branch that goes up here to your temporal bone. Looking at the red here now. The yellow. The rather small zygomaticofacial nerve serves as an afferent nerve for the skin of the cheek. This nerve pierces the frontal process of your zygomatic bone, at your zygomaticofacial foramen, and enters the orbit through its lateral wall. The other nerve, your zygomaticotemporal nerve, serves as an afferent nerve for your skin of your temporal region and pierces the temporal surface of your zygomatic bone at the zygomaticotemporal foramen. The infraorbital nerve, or your IO nerve, is an afferent nerve formed from the merger of your cutaneous branches from the upper lip, the medial part of the cheek, the side of the nose, and the lower eyelid, which is why when you get somebody numb here, you may have all those areas numb as well. Depending on how much you've administered and how much has gotten actually taken up. Your IO nerve then passes into the infraorbital foramen of your maxilla. Travels posteriorly through the infraorbital sulcus and canal. From the infraorbital canal and groove, the IO nerve passes into the pterygopalatine fossa through the inferior orbital fissure. So it passes in through here. Okay, so it comes in through here, passes through here. After it leaves the infraorbital groove and within the pterygopalatine fossa, your IO nerve receives the posterior superior alveolar nerve and joins with it or directly with the maxillary nerve. So our posterior superior, posterior meaning towards the back, superior meaning maxillary. Rate yourself to find out where it is. Okay. Alveolar, good anesthetize the teeth. Again, middle superior, anesthetize the first root of your mesiobuccal root of your first molar, as well as your premolars. Anterior superior alveolar is going to do your canine just to 8 or 9, depending on which side you're doing it. Okay, so when you get to the mesial part of 8 and 9, or 9, should I say, when you're scaling, they're going to start to feel it a little bit because the nerve's going to cross over because it only goes to that midline of 8 or 9. Okay, then you'd have to anesthetize the other side. Okay. So a lot of times what we'll do when we're scaling on a maxillary, we'll do a PSA, posterior superior alveolar. We'll do an MSA, middle superior alveolar. We'll do an ASA, anterior superior alveolar. That will numb or anesthetize that whole quadrant. Okay. Sometimes you have to anesthetize this other ASA in order to access, depending. Okay. If they need anesthesia for anything on the lingual aspect, then you would go to your incisive foramen area and do an incisive injection. Then you would also go to your greater palatine foramen. Okay, remember these foramina that we talked about on the skulls? Okay, and that will anesthetize all the lingual aspects. So, as you're learning these nerves and you're learning the block, I don't ask you a whole lot of anesthesia, but there will be some anesthesia on your exam. Okay, I suggest you really studying that colorful mouth. Okay, that chart that I showed you earlier. The ASA nerve originates from the dental branches in the pulp of these teeth that exits through the apical foramina nerve. Also receives the interdental branches from the surrounding periodontium, which together become part of your superior dental plexus within the maxillary arch. So basically what this is saying is that the nerves are coming into the apical foramen of each tooth. Okay, they enter and exit in the apical foramen. The superior dental plexus in the maxillary arch also receives interdental branches. What's interdental mean? Between teeth. Okay. From other branches of your maxillary nerve, both the middle, posterior, and superior alveolar nerves. The ASA nerve is also your anterior superior, that's what we call it. Then ascends along the anterior wall of your maxillary sinus to join your IO nerve within the infraorbital canal. So, again, if you follow it up, what was a plexus? Remember what a plexus was? Kind of a gathering. Okay, small gathering. Okay, a ganglion is when the major nerves are gathering together. Okay. So we have a superior dental plexus is just a set of nerves on the superior alveolar area. Follow this up, your anterior superior alveolar meets with your what? What's this nerve?
Maxillary. P2.
Maxillary nerve, your division 2 of your what?
Trigeminal.
Trigeminal, good. This area here, your middle superior alveolar, is a branch off of your maxillary nerve, division 2, trigeminal. What was this one?
Yes.
PSA, good. Posterior superior alveolar is branches off your B2. Okay, so we understand now. We have 3 branches off our trigeminal nerve. Off our maxillary, you're gonna have 3 branches here, right? We're gonna talk about the leaves. So basically the trunk, think of a tree. Trunk, branches, leaves. Okay. A dental plexus is a network of nerves within both the maxillary and mandibular dental arches. Okay, so you have a maxillary plexus and you have a mandibular plexus. Okay. Superior and inferior dental plexus. Crossover innervation is the overlap of terminal nerve fibers from the contralateral side of the dental arch, which is why we talked about here, if you take a look, when you are anesthetizing a patient, the mesial aspects of both 8 and 9, that's where your crossover is going to be. Same thing down here on 24 and 25. Okay, when you start getting onto the mesial aspect of 25, they're going to probably start feeling it. You have a couple of options. You can either inject and anesthetize that one individual tooth. You can use some topical anesthesia because usually they can kind of toughen through it. But you're never going to anesthetize both sides of these lobers at the same time. Because if you take a look at this picture here, it's going to anesthetize the whole side of the tongue. When you have both sides of the tongue anesthetized, the patient feels like their tongue is fat and then they can't breathe. Okay? And if you do it incorrectly, you're going to anesthetize the soft palate and then they really have a problem. Okay, so never, never, never anesthetize the whole left and the whole right. Okay, want to stick to one side. Your MSA nerve, if present, sometimes it's not, originates from the dental branches in the pulp that exits the teeth through the apical foramina, as well as the interdental and interradicular branches from the periodontium. What was interradicular? Do you remember? Between the roots. Interradicular, between the roots.
So you're saying some people don't have that range?
Is that a genetic effect or?
Yeah, more common than not, you will have it, but every once in a blue moon, a patient may not.
So then you feel any pain with any tooth that is associated with that nerve?
Well, they could still because of the interradicular and interdental,
Oh, okay.
right? So the MSA nerve then ascends to join the IO nerve by running in the lateral wall of the maxillary sinus. Your MSA nerve is not always present in all patients. It's present only in approximately 28% of the population. I have never had a problem with any of my patients not having this, so I don't know how that's fully accurate. If the MSA nerve is not present, the area is innervated by both the ASA and your PSA nerves, but mainly the ASA nerve. If the MSA nerve is present, there's also communication between the MSA nerve and both the ASA nerve and posterior superior alveolar because it's in the middle. If you take a look, they're really still all connected, right? By the main trunk. Okay. Take a look here. You're gonna get some from your PSA. It's gonna come down here, right? You're gonna get some from your ASA. And they communicate because they're all in the same plexus. Your PSA joins your IO in some of the, in some cases in the pterygopalatine fossa. Your PSA nerve serves as an afferent nerve for the mucous membranes of your maxillary sinus, maxillary molars, with the associated buccal periodontium and the gingiva. So when you do your PSA, if you take a look at the colored chart there, okay, it gives you a little guide on the side. It's going to anesthetize the tissue right here and the teeth. Okay, now this mesial buccal cusp sometimes can be anesthetized by this, and sometimes it is not. The only way to know is if you test it on your patient. Okay. So typically after I do anesthesia, I'll go in with my probe, I'll check molars, ask them how they're feeling. I'll check premolars, ask them how they're feeling. I'll check anteriors, ask them how they're feeling. That way I know, okay, well, where is that anesthesia at? Do they need more, and where do I need to anesthetize that? Okay, because you don't want to sit there, especially for a lower, you don't want to give a whole nerve block for blocking off the whole thing if you don't need that much. And you want to administer the least amount of the drug possible to get the greatest effect. Right? So if a patient is still feeling it here on the anteriors only, I'm not going to anesthetize the whole darn thing. A, it's going to take too long to travel, but why anesthetize that whole area to waste it when all this is already numb and I only need to be numb up here? Right? So sometimes it takes a little bit of critical thinking. Okay? Same thing here. So if the patient's already numb on the molars, but when I get to that mesial aspect of number 3 or 14 and they're starting to feel it, then I need to decide, okay, am I going to anesthetize just that tooth? How are the premolars doing? Are the premolars numb or are they not? If they're not, then I'm going to do an MSA. That should knock it out. See how that kind of works out? Makes sense? All these internal branches of your PSA nerve enter multiple posterior superior alveolar foramina on the surface of your maxilla. PSA nerve then moves superiorly along your maxillary tuberosity, which forms the posterior lateral wall of your maxillary sinus to join either the IO or your maxillary nerve. The PSA nerve, like the ASA and MSA, is part of the superior dental plexus of your maxillary arch. Remember, that's on one side. It's going to mimic the same thing on the other side. Okay. Your greater palatine nerve, or your GP nerve, is located between the mucoperiosteum and bone of the hard, posterior hard palate. The GP nerve serves as an afferent nerve for the posterior hard palate and the associated palatal periodontium and gingiva of the ipsilateral maxillary posterior teeth. Okay. So your GP, your greater palatine, okay, so you're going to be targeting your greater palatine foramina, which typically is by the distal aspect of your second molar. Okay, you're going to be taking a Q-tip, basically. You'll start at your first molar and kind of drag it down until you kind of fall into this little foramina. You'll feel it. Okay, but you want to be careful not to rub the Q-tip all over the palate because it's very sensitive and it tickles a lot, and you're going to get your patient to gag. We do not teach you to use any type of topical when we're doing injections on the maxilla because it activates the salivary glands to produce more saliva there, but it's also going to make things a little bit more slippery. So we use a dry, oh my gosh, just lost it. Q-tip, thank you. Dry Q-tip to kind of find our spot, apply pressure, and then inject right next to it. Okay, the pressure aspect actually really works pretty well, sometimes way better than doing topical. Okay. You don't want to sit your Q-tip over top of this because then you're going to block where any anesthesia is going to need to go. So you're going to stop your, you'll find it, put your pressure next to it, and you're going to inject right outside. Posteriorly, your GP nerve enters your greater palatine foramina or foramen in the horizontal plate of your palatine bone, near the maxillary second or third molar to travel within the pterygopalatine canal, along with your greater palatine blood vessels. Okay, so remember your horizontal plates here. Okay, remember where your foramina is, typically here. The lesser palatine nerve, or your LP nerve, serves as an afferent nerve for the soft palate and palatine tonsils. It enters the lesser palatine foramen in the palatine bone near its junction with the pterygoid process of your sphenoid, along with the lesser palatine blood vessels. The LP nerve then joins the GP nerve with the pterygopalatine canal. You will not be doing anesthesia on your LP nerve. I am not going to ask you about that, just except for basic questions, you know, to target the hard palate, would you inject on the LP or the GP, kind of thing. Nothing really overwhelming, because LP you should never be targeting for. We're not looking to anesthetize our soft palate. Right. We're not going to work back there. And if you're removing tonsils, then you're not a hygienist. Both palatine nerves move superiorly through the pterygopalatine canal towards your maxillary nerve in your pterygopalatine fossa. On the way, the palatine nerves are joined by lateral nasal branches, which are afferent nerves from the posterior nasal cavity. So this nerve serves as an afferent nerve for your anterior hard palate and associated palatal periodontium and gingiva of your maxillary anterior teeth on both sides from canine to canine, as well as your nasal septal tissue. So when we look here, it's only going to be on this lingual aspect, only on the palatine area, nasopalatine. Okay, it's not going to do anything out here on the buccal regions or the teeth. It's only for the tissue. You're going to be targeting on your incisive foramen. So again, you'll be utilizing a Q-tip to put pressure on the side of this foramina, and then you'll inject into the actual foramen itself. Okay, you don't need much here. You don't need much solution here, so it's not a very long one. Both the right and left NP nerves enter the incisive canal by way of the incisive foramen, located between the articulating palatine process of your maxilla and deep to the incisive papilla, thus exiting the oral cavity. So again, you're going to have your incisive papilla here. That's what you're going to be seeing, because you can't see the foramen. Your Q-tip's going to be on the side, depending on which side you are working on. Okay, so it's going to be on the side of the incisive foramen. You're going to be targeting basically your needle, if you will, into the actual incisive papilla. Right underneath that's where the foramen is. This kind of gives you a little bit of a view of where those branches are going to be going from canine to canine. Okay. This gives you the branches of your greater palatine nerve, showing you that it's going to anesthetize this whole side of the palate. Notice how these branches terminate and the other side has its own set. Okay, they kind of meet in the middle, but they don't cross over. Okay, and then your lesser palatine, again, we're not worrying about because it's going to anesthetize the throat, which we don't need. Go ahead and take a 10-minute break. I'm starting with you guys.
Yeah.
All right, so our mandibular nerve, okay, it's our third division of our trigeminal nerve, which is a short main trunk formed by the merger of a smaller anterior trunk and larger posterior trunk with the infratemporal fossa deep to the base of the skull before the nerve passes through the foraminal valley of your sphenoid bone. Okay, so this is going to come off of our ganglia all the way down here. Now, you can see how it's got little branches here. Okay, the mandibular nerve is a little bit different than your maxillary in the fact of when you anesthetize back here, it's going to anesthetize this whole area typically, versus on the upper areas, because they have all of the different branches coming off of the main trunk, you have to anesthetize 3 different injections. Okay, sometimes more. Okay. The mandibular nerve is the largest of the three nerve divisions that form the trigeminal nerve. The mandibular nerve is also a mixed nerve with both afferent and efferent. Additionally, it contains the entire efferent part of your trigeminal nerve. Okay, so there's only one division of your trigeminal that is efferent, and that is your mandibular. If you can remember, that's the only part that moves. It's the only motor part. Okay. A few small branches arise from the mandibular trunk before its separation into the anterior and posterior trunks. These branches from the undivided mandibular nerve include the meningeal branches, which are afferent nerves for parts of the dura mater. Also the medial pterygoid nerve, which is the efferent nerve from your medial pterygoid and tensor veli palatini muscles, as well as the muscle of your middle ear, the tensor tympani. Bless you. Okay, so when we're looking here, familiarize yourself here. This is going to be your mandibular branch. Okay, coming down to feed the leaves into the actual teeth. Versus on your maxillary, you had the main trunk, you had the branch, and then you had the leaves coming off. This is just one big trunk with leaves. Okay, which is why when you anesthetize back here and you're targeting this main nerve, it's going to anesthetize all these little areas. Okay. The anterior trunk or the anterior division of the mandibular nerve is formed by the merger of your buccal nerve and your muscular nerve. The anterior trunk has both afferent and efferent. Your buccal nerve, or your long buccal is what we call it, serves as an afferent nerve for the skin of the cheek, the buccal mucosa, as well as the associated buccal periodontium and gingiva of your mandibular molars. The buccal nerve is located on the surface of your buccinator muscle. The buccal nerve then travels posteriorly in the cheek deep to the masseter muscle. So if you take a look over here, the buccal, which is this yellow area, is only going to anesthetize the buccal tissue of your molars and your cheek area. Right? Whereas your IA is going to do your side of your tongue, all of your teeth, and then the skin and tissues of buccal area here. So when we do a nerve block on the lower, and we're trying to anesthetize all of the lower or a tooth on the lower, it's actually 2 injections. Because you're targeting your inferior alveolar, which is what IA is. You're targeting your IA, and then you're coming down here to target your buccal. Okay, so it's 2 different sites, 2 different nerves, 2 different branches. Okay. The buccal nerve then passes anteriorly to the anterior border of the mandibular ramus, distal and buccals to the most distal mandibular molar, and goes between the 2 heads of your lateral pterygoid. Okay, so here's your mandibular nerve. Right? And here's your buccal nerve. Several muscular branches are part of the anterior trunk of the mandibular division. They arise from the motor root of the trigeminal nerve. The deep temporal nerves, usually 2 in number, with both anterior and posterior nerves, are efferent nerves that pass between your sphenoid bone and your superior head of your lateral pterygoid muscle and turn around the infratemporal crest of your sphenoid bone to terminate in the deep surface of your temporalis muscle that they innervate. So your deep temporal nerves innervate your temporalis muscle. The posterior deep temporal nerve may arise in common with the masseteric nerve, and the anterior temporal nerve may be associated at its origin with the buccal. So when you take a look here, your masseteric runs kind of along where your buccal nerve is going to be going, okay, as well as your temporal going up to your temporalis. If you look at the red, it's all branches off of your mandibular nerve. Okay, your mesenteric nerve is also an efferent nerve that passes between your sphenoid bone and your superior border of your lateral pterygoid muscle. The lateral pterygoid nerve, after a short course, enters the deep surface of your lateral pterygoid muscle between the muscle's two heads of origin and serves as an efferent nerve for your lateral pterygoid muscle. Yes, I skipped some information in there. I know, you guys looked at me and saw it. Underline what I say. The posterior trunk or posterior division of your mandibular nerve is formed by the merger of your auriculotemporal lingual and inferior alveolar nerves. Your posterior trunk has both afferent and efferent nerves. Your auriculotemporal nerve travels with the superficial temporal artery and vein and serves as an afferent nerve for the external ear and scalp. Auriculo meaning ear, temporal up by your temporal muscle where your scalp would lie over, right? It also carries fibers to your parotid salivary gland. Important to note is that these fibers arise from the lesser petrosal branch of your glossopharyngeal or your ninth cranial nerve, joining the auricular temporal nerve only after relaying in the otic ganglion near your foramen ovale. Communication with the auricular temporal nerve with the facial nerve near the ear also occurs. So basically from this slide, all I want you to understand is that some fibers go to the parotid salivary gland. Your lingual nerve is formed from your afferent branches from the associated lingual periodontium and gingiva of your mandibular teeth and from the body of the tongue. It first travels along the lateral surface of your tongue. Lingual meaning tongue, so lingual nerve going in through your tongue. So here's your lingual nerve going on the lingual aspect of the teeth by your tongue. Okay, whereas your buccal nerve was going where? Cheek side. Bless you. Your inferior alveolar nerve goes in here, but then remember feeds all of the teeth and the tissue here. Okay, so not to get confused with this one. Your mylohyoid is coming a little bit farther down and going more anterior. So if you look at an image like this and you're studying it, try to orient yourself on where these are all going. Okay.
And that's the hyoid bond.
Yeah. Where it lies in. The nerve then passes posteriorly, passing from the medial to the lateral side of the duct of your submandibular salivary gland by going inferior to your duct. Okay, so your ducts, your glands are down here to orient yourself. Okay, your submandibular salivary gland is going to be a little bit more posterior versus your sublingual. Okay, so it's going by your submandibular salivary gland, going underneath the duct. Your lingual nerve communicates with the submandibular ganglion located deep to the lobe of the submandibular salivary gland. This ganglion is part of the parasympathetic system. Parasympathetic efferent innervation for the sublingual and submandibular salivary glands arise from the facial nerve, more specifically the chorda tympani nerve, which travels along with the lingual nerve. Lingual nerve serves as an afferent nerve for general sensation for the body of the tongue, the floor of the mouth, and the associated lingual periodontium and gingiva of the mandibular teeth to the midline. So remember, you're going to have one on each side. It's going to terminate at the midline. So current thought has implicated most of the paresthesia of the mandible after local anesthesia administration with trauma to this nerve. So you can actually have caused trauma to your lingual nerve and have anesthesia elsewhere. You know, paresthesia of your mandible. Inferior alveolar nerve, or your IA nerve, is an afferent nerve formed from the merger of the mental and incisive nerves. Your mental nerve is going to come out to where your mental foramen is. Okay, here's your incisive nerves going to your incisors. Okay, inferior alveolar, inferior meaning lower. Okay, so now you're talking mandible, inferior, lower. Alveolar is going to anesthetize the teeth, right? Right. After forming, the IA nerve continues to travel posteriorly through the mandibular canal along with the inferior alveolar artery and vein. The IA nerve is joined by dental branches such as your interdental and interradicular branches from surrounding periodontium to be part of your inferior dental plexus. Again, the gathering of all of these down here, your mandibular plexus, also known as your inferior dental plexus. The IA nerve then exits the mandible through the mandibular foramen, an opening of the mandibular canal on the medial surface of the mandibular ramus, in which also travels the inferior alveolar blood vessels. The IA nerve is then joined by the nearby mylohyoid nerve. Okay, remember your mylohyoid nerve is one that comes down here, right, to join up. Right? You have to do a lot of tracing when you're studying these. The mandibular foramen position is approximately 2/3 the distance from the coronoid notch to the posterior border of your mandible. Excuse me, mandibular ramus, entirely with a pterygomandibular space. This is important to know when you're doing local anesthesia. Because when you're doing local anesthesia, you're having the patient open, you're taking your thumb to feel for that coronoid notch, bringing your thumb outwards, and then you need to know, you're going to see a little triangle, and you need to know where the 2/3 is. Okay? Because you're kind of guesstimating a little bit, right? Because you can't see, right? So you kind of have to know a little bit of your anatomy. The IA nerve then travels lateral to the medial pterygoid muscle between the sphenomandibular ligament and ramus of the mandible. This is posterior and slightly lateral to the lingual nerve. Your IA nerve then joins your posterior trunk of your third division. Okay, so let me go back to this other image here. So basically, this will be the inside where your tongue is going to lie against, right? So you're going to be taking your thumb and running it out this way to get good retraction, but you're also feeling for where your coronoid notch is so that you understand where your anatomy might be and where those nerves are coming from, okay, or coming out of. Because you're targeting essentially right here, okay? So if you target this area here, you're going to end up anesthetizing this area here, right? And then it's branches. So if you target here, the branches are going to get it as well. Does that make sense? Now you'll be targeting way up here. Although some dentists will, and sometimes you have to target higher. Every body is not the same, right? So in some instances, you need to look at your panoramic x-ray and see kind of where these nerves are really coming out of. Some people, it's a lot higher than others. You could be doing an inferior alveolar nerve block and not getting a patient numb and you're wondering why. Right? Sometimes you have to go target a little bit higher on the trunk of the nerve versus its branches. But if you can't get a person numb the first time, you try it again. If you can't get it numb the second time and you want to get some other eyeballs in there, try it then. You'll have your dentist do it. Here is a little bit different. We run things a little bit differently, but in private practice, you don't want to just keep shooting up your friend if you don't know where you're really going, right? You want to get somebody else in there. Right. I worked for a dentist that she had the hardest time getting people numb on inferior alveolar nerve block. Finally, at one point, she asked me to come in. I don't know, but some people have a really hard time with it. It's one of the hardest ones to anesthetize because it is so long and because you have to have a good idea of where those nerves are really exiting and coming from in order to anesthetize the patient. But also has a long area of travel. So when you do this type of nerve block, you're going to give the patient the anesthesia, but then you want them to sit up because you want that anesthesia to come forward and help let gravity kind of help you out. Okay? If you leave them back, it's just going to kind of still pull right there. It's going to take forever. And you're on a time crunch when you've got a patient chair, right? Time's money, at least time. right? So you want to get working as fast as you can. So long as you set that patient up for a couple minutes, you can talk to them if you want to, whatever, and then check them in a couple minutes. Say, how is your lip feeling? How is the side of your tongue feeling? You know, and if they're saying, well, it's feeling numb, okay, well, I'm gonna lay you back and I'm gonna check your teeth and make sure that we're okay. Because you don't want the patient to be uncomfortable, be comfortable as possible, because typically when you have to do anesthesia, they're already scared,
Yeah.
right? And they're scared of the procedure you're about to do. So you wanna make sure they're as comfortable as possible. So I'll take my probe, like I said, and I'll check molars, premolars, and then the anteriors and kind of see where you need to go. Do they need to have more or are they okay? Some people are really sensitive to it. I was really sensitive to it. I feel like I am. My anesthesia lasts me about 8 hours. I usually typically go home, put a heating pad on and take a nap. It makes me really tired. However, the last time I got a filling done, which was earlier this year, I got my filling done because it broke. And she asked me, my dentist asked me, she said, are you easy to numb? I said, oh, yeah, really easy. And it lasts forever. It's the middle of the day. I was on my lunch. That was a bunch of baloney because she couldn't get me numb. She's like, she tried every type of injection, hurt like hell get out, every type of injection she could. And by the end of the day, or by the end of the appointment, I was so numb. But anesthesia works different on everybody. So remember I said it makes you tired, but it also makes me really cold internally. Wasn't cold in the office, but I was internally cold. I was shaking uncontrollably because I was so cold. I had a heating pad, I had a blanket, I'm trying to eat my soup. It wasn't really happening because it's kind of coming out the other way. I'm so numb. But my numbing wore off before the end of the day. I had to see patients. My numbing wore off by the end of the day, which is weird for me. So again, every person's different, every body is different. Every tooth situation is going to be different. If you have a tooth that has an infection on it, you're not going to be able to get the patient numb because you're going to have an infection there and stop the anesthesia from actually working, which is why they typically put you on antibiotics to get the infection down so that you can get it. Right? There's a reason for all that. But like I said, every situation is going to be a little bit different. And every doctor is going to be different. How they administer and how much they give you and what kind they give you and the reason behind it. I worked for someone for a very short period of time who would still heat the cartridges. We do not heat cartridges, we heat them, warm them up. The thought process back in the day was that if you warmed it up, well, you're internally warm, right? So it'd be more comfortable. Wrong. He also would basically stab you as he's going in. You don't do any of that. You want to be nice and gentle as you can. We don't do any shaking here. You'll see dentists that maybe do shaking. That's really kind of to take the mind off of it, but let's think about this. You got a sharp needle in there and tissue, and now you're shaking and manipulating the tissue all around that needle. Not the best idea, right? They do have devices that can vibrate. It's called dental vibe. It looks like prongs like this, and you put it around the site that you're going to be injecting on, and you would inject between the two prongs. I personally don't love it. Some people really do. It takes your mind, it's a mind trick. It takes your mind off of
It's cheap.
the
I've seen the
injection.
vibrating ones.
It's vibrating. It just, it's like, it vibrates your tissues. It's not actually maneuvering it, right? So it's not manipulating it across the needle, just vibrating. Some people like
I
it,
like
some
the
people hate it. It's loud. I personally.
The needles don't bother me anyway,
Well, it's
so.
not the needle, it's the solution. So the pH of the solution and the pH that's what's in your tissue are different, and that's what you feel. It's not the actual needle.
Oh, that's the pain.
It's like
Yeah.
oh, yeah.
Yeah,
Yeah, because it goes
It
across,
gets
it's not just in
injected.
one area, you feel like,
Travel.
right, and it disperses.
that's what I don't like,
Right.
I don't like feeling it.
Yeah, well, wait till you get your anesthetic.
Yeah, I know.
Okay. So the mandibular foramen position is approximately 2/3 the distance from the coronoid notch to the posterior border of your mandibular ramus, entirely within the pterygomandibular space. Your IA nerve then travels lateral to the medial pterygoid muscle between the sphenomandibular ligament and the ramus of the mandible. This is a posterior and slightly lateral to the lingual nerve. Your IA nerve then joins your posterior trunk of your mandibular division. So, when you're looking at it at a side view, you have your inferior alveolar nerve, okay? This branch is coming down here, okay? It's going to exit out of what foramen?
Mental.
Okay, so your mental foramen, which we can't see on this because he's got his tissue or his muscle in the way, okay? And then those leaves are going to anesthetize all the teeth from your inferior plexus. Okay. Your IA nerve carries the afferent innervation for your mandibular teeth and associated facial periodontium and gingiva of your mandibular anterior teeth and premolars, as well as your labial mucosa, your lips, through its incisive and mental branches. So when you look at this image here, you want to take a look at IA, all this green area. So it's going to anesthetize all the mandibular teeth, as well as the anterior labial mucosa. When you get to the posterior labial mucosa and gingiva, it's going to be your buccal nerve. And again, when you get to 24-25 area, that's where the nerve terminates. Okay, yeah.
But is the buccal getting the side of the tooth, or is it
Just the
just the tissue? Okay.
Yeah, remember anything that has the word alveolar is going to be teeth.
Okay.
Okay. Buccal is not buccal alveolar, it's just buccal. Okay, so just be the tissue. The mental nerve is composed of external branches that serve as the afferent nerves for the chin, lower lip, and labial mucosa, as well as the associated facial periodontium and gingiva of your mandibular anterior teeth and premolars to the midline. 425. Your mental nerve then enters the mental foramen on the lateral surface of your mandible. Okay, so here's your mental nerve. Okay, it's going to have incisive branches off. It's going to have mental branches to your chin. Your mental foramen on the lateral surface of the mandible, usually inferior to the apices of your mandibular premolars, in which the mental blood vessels also travel. So you can see it on an X-ray. It's going to look like a black void. Okay, typically between your premolars or by your second premolar here. This is a nice image of it. Sometimes it's not that easy to see. But that's going to be your target spot if you are doing a different type of injection, which we'll talk about in a second. After entering the mental foramen and traveling a distance within the mandibular canal, the mental nerve merges with the incisive nerve to form the IA within the mandibular canal and before your mandibular foramen. So this nerve is going to connect with your inferior alveolar. Your incisive nerve is an afferent nerve composed of dental branches from the mandibular anterior teeth and premolars that originate in the pulp, exit the teeth through the apical foramina, and join with the interdental branches to form the surrounding periodontium to be part of the inferior dental plexus of your mandibular arch. So these incisive nerves are going to feed your incisors, your lower incisors. It's also going to meet up with the main trunk of the nerve, okay, before it gets out to your mental nerve. The incisive nerve travels along with the incisive blood vessels within the mandibular incisive canal, which is an anterior continuation of your mandibular canal that runs bilaterally from the mental foramen, usually to the region of the ipsilateral lateral incisor teeth. So with these teeth, you can anesthetize each tooth individually. Some states do not allow hygienists to do a whole nerve block. So sometimes you actually have to anesthetize each tooth individually, which can be terrible for the patient, it can be terrible for you. I used to work with a hygienist who was from New York, and they were not allowed to do nerve blocks. It may have changed now because it was several years ago, but just know that when you go to a different state, the laws may be different, and you need to make sure that you know what those laws are, so that you don't end up doing something that you're not allowed to do and then you get sued. Okay. So when we are targeting an MI or mental incisive, we are targeting for where that mental foramen is in our mandibular foramen, and you're trying to get your premolars anesthetized forward. So if I have a patient that is numb on the molars, but not so much on the premolars forward, that's where I'm going to target at. If I have a patient that's completely numb here, but let's say not on 23, I'm just going to anesthetize 23. Okay. So again, administering the least amount of the drug for the maximum benefit. Why would I waste all my anesthesia material back here when they're already numb? Plus, it's gonna take a lot longer. Whereas I can just get them numb right here and I'm fine. Okay, so sometimes we gotta really critically think. Some of that's a little bit beyond where you guys are at right now, but starting to critically think so that you understand where those nerves are going and what they're affecting. So your incisive nerve serves as an afferent nerve for the mandibular anterior teeth and premolars, and associated facial periodontium and gingiva to the midline. Okay, so when you look here, IN is incisive nerve, goes from your premolars to that crossover midline, only doing the teeth and the buccal tissue, as well as not getting this area here, which would be what your IA would get, right? Incisive nerve then merges with the mental nerve just posterior to your mental foramen. It either terminates, has nerve endings with the mandibular anterior teeth or adjacent lingual cortical bone in soft tissue. That is a very blurry picture if you blow it up, but it's showing you the foramen. Crossover innervation, again, is where those one terminates and the other one terminates, and they kind of come together. After the inferior alveolar nerve exits the mandibular foramen, a small branch occurs, the mylohyoid nerve. Okay, so when you take a look here, your mylohyoid nerve here. It serves as an efferent nerve to the mylohyoid muscle and anterior belly of your digastric muscle. The mylohyoid nerve pierces the sphenomandibular ligament and runs inferiorly and anteriorly in the mylohyoid groove, and then onto the inferior surface of your mylohyoid muscle. Some of that we talked about last week. I don't like standing here. With shingles or herpes zoster, unilateral, meaning on one side, painful vesicles, vesicles are like sores, okay, and or ulcers, follow the pathway of the involved nerve. The facial area served by ophthalmic nerve or division of your trigeminal nerve is most commonly affected. You would never work on a patient that has active situation going on. Good. Trigeminal neuralgia, or TN, is also known as tic douloureux, has no known cause, but involves the afferent nerve of the fifth cranial or trigeminal nerve. It usually involves the maxillary or mandibular nerve branches, but not your ophthalmic branch. The theory is that the lesion is caused by pressure on the sensory root of your trigeminal ganglion by blood area blood vessels. The patient may feel excruciating short-term pain on one side of the face when facial trigger zones are touched, or even when speaking or masticating, setting off associated brief muscle spasms or tics in the area. These trigger zones vary among patients, but can include areas around each eye or the hollow of the nose. The right side of the face, along with its regions and structures, is affected more commonly than the left. The pattern of pain follows along the pathway of the fifth cranial or trigeminal nerve branch involved. I have had one patient in my career that has had this, and she basically lived in pain like every single day. I mean, she could not, even if she went like this just to wipe a hair off of her or had an itch, excruciating pain. Treatment for trigeminal neuralgia can include peripheral neurectomy by surgery. Ectomy means to remove, okay? Or ultrasonic treatment in which the sensory root of a trigeminal nerve is sectioned, cutting off innervation to the tissue. Injection of the trigeminal nerve with various chemicals has also been used to cause necrosis of the nerve, as have systemic antidepressant and anticonvulsant drugs with varying degrees of success. However, when you start doing these types of medications, that starts causing a whole bunch of other problems, such as dry mouth. Okay. You can also have reactions to these in different ways to where it's not really working as an antidepressant, but it's working as a depressant. Okay. You can also have enlargement of your gum tissue sometimes. What?
I said gingiva.
Yep. So, research now points to a complex cascade of chemical releases that aggravate the trigeminal nerve. So it's being called the migraine nerve. It turns out that many sinus headaches are actually migraine. Trigeminal nerve fibers coursed through the tissue over the sinuses. Inflammation involving the nerve and surrounding tissues can theoretically be stopped by drugs designed to lock up the response. So when you look at this image here, it's one I kind of skipped over earlier, but it's kind of showing you this different divisions. Okay, so the blue is going to be your division 1 of your trigeminal. The lighter blue is going to be division 3 of your trigeminal, and this pinkish color is going to be division 2. Okay, so keep in mind that just because this is division 3, it's not just your mandible, but also part of your ear and part of your scalp. Okay, and this kind of tells you the nerve. So your buccal nerve, your mental nerve, your infraorbital, zygomaticofacial, etc. All right, going on to our facial nerve, number 7. The dental professional must have an understanding of this 7th cranial nerve. It emerges from the brain and enters the internal acoustic meatus on the teres part of the temporal bone. Within the bone, the facial nerve gives off a small efferent branch to the muscle in the middle ear. Don't need to know this part right here. And 2 larger branches, the greater petrosal and the chorda tympani, both of which carry parasympathetic fibers. The main trunk of your facial nerve emerges from the skull through the stylomastoid foramen of your temporal bone and gives off 2 branches. Your posterior auricular nerve and a branch to your posterior belly orodigastric muscle and stylohyoid. So your posterior auricular nerve is going to do such. Just go directly behind your ear, posterior auricular. Facial nerve then passes into the parotid salivary gland and divides the gland into superficial and deep lobes. You need to know that. If I ask you what nerve divides the parotid gland, you need to know which one. The trunk of the facial nerve itself divides into numerous branches to supply the muscles of facial expression, but does not innervate the parotid salivary gland itself. Which is saying it's not a nerve for the salivary gland itself. Just runs through it. The facial nerve carries both efferent and afferent nerves. The nerve carries an efferent component for the muscles of facial expression and for a preganglionic parasympathetic innervation of your lacrimal gland, as well as your submandibular and sublingual salivary glands. Your greater petrosal nerve is a branch off the facial nerve before it exits the skull. So if you take a look here at your facial nerve, kind of comes up by your ear, comes down, your greater petrosal is here before it exits the skull. Your greater petrosal nerve carries efferent nerve fibers to the pterygopalatine ganglion in the pterygopalatine fossa. The postganglionic fibers arising in the pterygopalatine ganglion then join with the branches of your maxillary nerve of your trigeminal to be carried to the lacrimal gland, your nasal cavity, and minor salivary glands of your hard and soft palate. The greater petrosal nerve also carries afferent nerve fibers for taste sensation in the palate, so know that. So when you have a full denture, it covers the roof of the mouth. So it's covering up some of these taste sensation areas, covering up some of these nerve fibers. They're not working as much. Now your taste sensation is extremely decreased. The small branch of the facial nerve is called your chorda tympani nerve. It's a parasympathetic efferent nerve for the submandibular and sublingual salivary gland. It also serves as an afferent nerve for taste sensation for the anterior 2/3 of the body of the tongue. It exits the skull by the pterygotympanic fissure, located immediately posterior to your TMJ. This nerve travels within the lingual nerve along the floor of the mouth in the same nerve bundle. Right here. The posterior auricular nerve, stylohyoid nerve, and posterior digastric nerve are branches of your facial nerve after it exits the stylomastoid foramen. They are all efferent nerves. Additional efferent nerve branches of your facial nerve originate within the parotid salivary gland and pass to the muscles they innervate. These branches to the muscles of facial expression include your temporal, zygomatic, buccal, mandibular, and cervical branches. They're rarely seen as 5 independent nerves. They may vary in number and connect irregularly. Like I said, each person is different, each body is different. The temporal branches supply the muscles anterior to the ear, frontal belly of your epicranial muscle, and superior part of your orbicularis oculi, as well as your corrugator supercilii muscle. What was that one?
Okay.
By your eyebrow, right? Your zygomatic branches supply your inferior part of your orbicularis oculi muscle and your zygomatic major and minor muscles. Your buccal branches supply your muscles of your upper lip, your nose, and your buccinator, your risorius, and your orbicularis oris muscles. The zygomatic and buccal branches are usually closely associated, exchanging many fibers. The mandibular branch supplies the muscles to the lower lip and your mentalis muscle. Should not be confused with the mandibular nerve from your trigeminal though. They're different. So like I said, you got to trace where that is coming from to see exactly which nerve it is. Cervical branch runs inferior to your mandible to supply the platysma muscle. Facial paralysis is a loss of muscular action to the muscles of the facial expression. This lesion can occur secondary to a brain injury by way of a stroke or your CVA. With other muscles of the head and neck also affected. This lesion can also occur by directly injuring the nerve that supplies the efferent nerves to the muscles of facial expression or your 7th nerve. Facial paralysis can be on one side or both sides, and transient or permanent depending on the nature of the nerve damage. These injuries can occur because the facial nerve branches are superficially located and vulnerable to trauma. So if somebody has a blunt force trauma, let's say even a car accident, or they get punched in the face, they're running their mouth too much, they can end up with facial paralysis. Okay, it depends on how much damage is done to the nerve, how extensive it is, whether it's going to be permanent, or whether they'll slightly get some back, or maybe they'll only have a little bit of feeling. Okay. When you have nerve damage, you're going to be a little bit asymmetric. Again, our infamous lady for Bell's palsy involves unilateral facial paralysis with no known cause except there's a loss of excitability of the involved facial nerve. Smiling on one side, trying to on the other, but it's not moving anywhere. Why would that be? So your brain's not telling the muscles to be activated to actually smile because the nerve isn't working, right? All or just some branches of your facial nerve may be affected with Bell's palsy. The onset of the paralysis is abrupt, and most symptoms reach the peak in 2 days. The theory of its cause is that the facial nerve becomes inflamed with a temporal bone, possibly with a viral etiology. It may undergo remission or become chronic depending on the amount of loss of facial nerve excitability. No specific treatment exists, but early injections and anti-inflammatory or antiviral medications or physical therapy may be helpful. Avoiding anesthesia of this nerve at this location with the parotid salivary gland is important when administering an inferior alveolar block or Vazarini-Yakunowski mandibular block because it may result in transient facial paralysis if administered incorrectly. Okay, so you can actually cause a patient permanent damage. which is why when we get to local anesthesia, we really need to pay attention. We hover you like, say something else, but we hover over you.
Gotta cut them off.
We hover over you pretty closely. You're not gonna be doing anything, without us being right there. Okay, so you would basically be targeting with a dry Q-tip or a wet Q-tip, and then you're gonna be targeting with topical. Then you can target, with a fake needle. We have a little ball on the end of a blunt needle. You can target that way to get the real feel, and then you can actually do your injection. So there's a lot of different steps that we take before you actually inject someone here, especially when you guys are learning. Okay, so just know that as long as you're following exactly where we go, or exactly what we talk about, you'll be fine. Don't try to get all tricky and cool and try to do your own thing. Okay, you'll end up having a problem. Another thing that they've been doing now for a lot of like facial nerve pain is Botox. So people having TMJ problems, they're using Botox to help with that. So it does have therapeutic effects, not just looks. And some dentists are doing that. If you have a extra certification, like one of the dentists that is in my practice, she has a certification to do Botox. She does a lot for like patients with migraines, patients with TMJ, or patients that are just wanting.
Where does it go for the TMJ? Like right into the joint or?
Yeah, there's a bunch of different sites. I don't know specifically, but yes, there's a bunch of different specific sites that it would go. And each person takes a different amount. So, like I had one patient that came in, she was a new patient, and she had an exorbitant amount of vials that she was getting previously at her dentist. And my dentist is absolutely not doing that many things. It's too much. You end up building up a tolerance, and then you just, once you started, it's not like you can just stop, right?
Yeah.
So, and especially now when the younger generation is starting on getting all these lip fillers and things like that, it's not that you can just stop and let it go. It really has an effect over time. You got to think about that for those of you that are getting that done, or your friends that are getting that done.
Yeah.
Botox can be good and bad at the same time. Just gotta know your stuff. So the injury to the facial nerve can occur secondary to an injury of the parotid salivary gland or surrounding region. So cancer occurs within the parotid salivary gland. The facial nerve can be injured because it travels through this gland. And that, my friends, is part 2. Okay. Okay. Anatomy of local anesthesia, chapter 9, part 1. The management of pain through local anesthesia by dental professionals requires a thorough knowledge of the anatomy of the skull, trigeminal nerve, which was your what nerve? What number? 5. Okay, and its related structures. The trigeminal nerve provides the sensory information for the teeth and associated tissues. Branches of your trigeminal nerve are anesthetized prior to most dental procedures, including the maxillary nerve and your mandibular nerve. Each of the 3 nerves or divisions of your sensory root of your trigeminal nerve enters the skull in one of 3 different locations in your sphenoid bone. Some of this is going to be a review because this is talking about local anesthesia. The ophthalmic nerve is your division 1. 1, entering through your superior orbital fissure. Your maxillary nerve is division what? 2, entering by way of your foramen rotunda. Mandibular nerve is division 3, passing through the skull by way of your foramen ovale. So make sure that you know those 3. The motor root accompanies the mandibular nerve of the sensory root and also exits the skull through the foramen ovale. Okay, it's going to be your mandibular. 2 types of local anesthetic injections are commonly used in dentistry: a nerve block and a supraperiosteal injection. The type of injection used for a given dental procedure is determined by the type and length of the procedure. Something that we do in hygiene is not going to need the same type of anesthesia, same concentration of anesthesia as somebody going through oral surgery, right? Because they're going to be in there for a few hours, whereas you're going to be in there for maybe an hour or 2, okay? So you got to understand your different types of anesthesia and what type that you're going for. A nerve block in dentistry usually affects a larger area of anesthesia than a supraperiosteal injection and thus additional teeth. With the nerve block, the anesthetic agent is deposited near larger nerve trunks. This type is mainly discussed with its more complex anatomic basis. In this photo, they're doing an inferior alveolar nerve block. Okay. They're going to be targeting your IA right here. Okay. So basically, I don't know why they're using their finger, but you use your thumb, you take your thumb right here where the coronoid notch is, you drag your thumb out at about 2/3 the height of that triangle that's right here is where your injection site is, staying from the corner of the mouth or over your premolars. If you start drifting this way with your needle, you're going to be missing your target. Okay? Your buckle is going to be down here. A supraperiosteal injection in dentistry anesthetizes a small area as compared to the nerve block, usually one tooth and associated structures, by injection near the apex or apices of the tooth. For this type of local anesthetic injection, the local anesthetic agent is deposited near smaller terminal branches of the larger nerve trunks. So for instance, like I said, if that patient is not numb or not anesthetized on number 23, I can go in and do a supraperiosteal type of injection. Okay, or infiltration is what we really call it, infiltration, and just anesthetize that one tooth. Right. In this situation, they're targeting more of like the lingual nerve to get the lingual aspect of 19. We don't teach you how to do that injection. We teach you infiltration, but not this particular one. Most local anesthesia of the maxilla is more clinically effective than that of the mandible because the facial cortical plate of your maxilla is less dense and more porous than that of your mandible over similar teeth. And anesthesia from the palatal surface is also possible. So you end up getting anesthetized a lot faster for your maxillary teeth. You don't have to sit there and wait like you do on your mandibular. Remember I said you should sit your patient up and let it kind of run down, whereas in your maxillary, you give the injection, you pretty much just, right? So it's much quicker. Maxillary facial anesthesia has a high level of clinical effectiveness when administered correctly, as everything else, as it anesthetizes both the pulp and various parts of the associated periodontium and gingiva. Pulpal anesthesia is achieved through anesthesia of each tooth's dental branches as they extend into the pulp by way of the apical foramen of the superior dental plexus. Those dental branches that they're talking about are those little leaves that go directly to the apex of the tooth. Okay. Both the hard and soft tissues of the associated periodontium and gingiva are anesthetized by way of interdental and interradicular branches for each tooth. So that solution is going to be moving, if you will, or kind of going down through all the different branches. So it's going to go through the branches, but off of these branches, you have like accessory branches that go in between the teeth. And off of that, you're going to have accessory branches that go in between the roots. That's what we're talking about. Okay, all kind of flows. So local anesthetic nerve blocks with the related structures that are anesthetized are located above. Note that the anterior, middle, superior alveolar, and the mental and the Gaugates or Bazzanari Akinoski mandibular blocks are not included. Okay, so basically this is saying to know that the borders of the injections and what's going to anesthetize what. Maxillary nerve. The anterior view of the skull with the maxilla highlighted in its bony articulations and features noted, such as the location of your maxillary sinuses, which is going to be your dashed lines. Okay, so your maxillary sinuses are located here. Okay, keep in mind where that trigeminal nerve is going to be coming down. Okay, your infraorbital is going to be going up here. Okay, so you can see how closely related it is to your sinuses. So when you have sinus trouble, you have pain in your teeth. Okay. So this is talking about kind of showing you the underside of the palate again. So your incisive foramen is going to be here, which would anesthetize from canine to canine on the lingual aspect only, so the palatal region. So let's say you're scaling a patient, they have a really deep palate hit on lingual number 9, and they're really feeling it, and they need more anesthesia, or they need anesthesia, you're going to do your incisive. Okay, which this one can be kind of hard to see because you got the patient laying back, but you try to see here, but you can't use the mirror. Right, because you have to use this hand to put the pressure, and you have to use this hand to do the anesthesia. So you're having the patient with their chin up as much as possible, and you're really having them to turn their head to one side or another, depending on if you're ready or left, where you're sitting, and trying to really see in there as much as you can. Sometimes with anesthesia, we have to break our ergonomics a little bit. And then again, with your greater palatine foramen to anesthetize what? What would this one anesthetize again? The hard palate, right? On one side, depending on which side you anesthetize. Okay. Your posterior superior alveolar block, PSA block, in most cases, anesthetize the maxillary molars and associated buccal periodontium and gingiva within one maxillary quadrant if the middle superior alveolar nerve is not present, which occurs, and see this as approximately 72% of cases. It's all over the place. Don't worry about it. Just know that sometimes your MSA is there and sometimes it's not. Okay. Okay, so your PSA, again, is going to be doing your posterior superior alveolar, which means it's going to be the teeth, those posterior molars. Okay, so your posterior molars, and sometimes not on that mesiobuccal root of your first molar there. In some cases, the mesiobuccal root of your maxillary first molar is not innervated by your PSA, but rather the MSA. See, now we're back to 28%. Therefore, a second injection to anesthetize the middle superior alveolar nerve by the block of the same nerve is recommended to ensure the correct anesthesia. So sometimes you have to do your MSA to get the full PSA. Okay. If anesthesia of the associated palatal periodontium and gingiva of these teeth is necessary, administration of the GP or your greater palatine block may be indicated. What if I have a patient that has tooth number 14 and 16, but not 15? What do you think I would do? We have two of the molars. Would I still do my PSA? Do you think?
Yeah.
Yeah. If they only had one of those molars, I probably wouldn't. I would just anesthetize that one molar. Right? If I had a patient that had no premolars, would I do my MSA? No.
Just directly the incisors.
Do your posterior, your molars and your incisors, exactly. So you do your ASA and your PSA. Now let's say I had that same situation and I did my PSA, but that mesiobuccal root of 14 is still not numb. What can I do? Anesthetize that single tooth as an infiltration. Okay. Just to target that one tooth. You just basically your anesthesia will go right above that tooth at the apex. Okay. All right. Sometimes it gets tricky if the patient has had ortho. Remember I said before, even if the patient has had ortho and they got one of their premolars removed, it doesn't change where the anatomy is of the foramen, right? It only changes what teeth are there. So you're still going to do your targeting in the same exact spot as you normally would have had both premolars. And we'll help you figure that out. Target area for your PSA block is the posterior superior alveolar nerve branches entering the posterior superior alveolar foramina in the infratemporal surface of your maxilla. Your PSA foramina are your posterior superior on the maxillary tuberosity as well as superior to the apices of your maxillary second molar. So basically what you do, there's a lot of verbiage in there. Basically what you do is you would take your pinky all the way back to your maxillary tuberosity and feel where it kind of falls in. And that's going to be your site of injection. Okay. You don't want to take your index finger because it's too big. A pinky is nice and small to really access that area, but that's what you're feeling for. You're feeling for that to really sink up in there, and that's where you want to target. Now, when you are targeting right there, that is what we call a high aspiration rate, meaning that when you do that type of injection, you are very likely to be in the wrong spot and get blood in your cartridge because you're in a blood vessel. Are we anesthetizing blood vessels? No. No, we're targeting nerves. So if you ever are in that area and you get blood in your cartridge, you need to come out a little bit and readjust yourself to get out of that and into the nerve itself. Okay, that happens sometimes. That is a really common spot for it to happen. Another really common spot for it to happen would be down here with your A, right? And also with your MI. So I like to have my students like make an L. Okay, and those two areas are going to be those three areas are going to be areas where you do like an aspiration, to pull back on the syringe to see if there's any blood in there, and then you do like a slight turn and see if there's any blood. You do another aspiration, see if there's any blood, and if there's not, then you eject. So it's kind of like when you are using your vacuum. Do you know what a crevice tool is?
Mhm.
So it's the one tool that's straight, but then it has like a side like this, so you can get like in the nooks and crannies. So let's say you're using that, right? And let's say there's a curtain right here and I'm stuck on the curtain. In order for me to get off that curtain, I have to turn it a little bit, right? To allow the airflow to get into that. Okay, it's the same thing with doing anesthesia. Okay, if I'm going in and I'm in a blood vessel, the only way to get off of that and actually get out of there is to turn it. Now, you want to make sure that you're not stuck up against the wall of anything, because if you start coming back and you start anesthetizing, you're going to get stuck on the wall and it's going to collapse. So you want to make sure that you come out a little bit, readjust yourself, and then try it again. Okay, so that's a little bit of dance for you guys right now, but just to understand that in those areas, there's also a lot of blood vessels that you can get into, and when you have blood in your cartridge, that's not a good sign. You want to get out of that. Okay. You're targeting nerves, not blood vessels. So when you're looking, okay, because this is what you're going to be seeing, right? You're not going to see that beautiful nerves coming out. Okay. So you're going to be looking at where your coronoid notch is. Okay, again, you're going to be coming in right here. Your injection site is essentially going to be right here, because that's where your inferior alveolar nerve block is coming. You're not going to be way over here, because it's going to be your lingual. Okay, we're not doing lingual injections. Okay, we're going to be more over here. We're not going way back here because we're not targeting our tonsils and the soft palate, not targeting anything on our lesser palatine. Okay, the inferior alveolar nerve block would be here. Your GP would be right up here. Okay, your buccal will be just on the side of your last molar here. Just weird there. The injection site for the PSA block is within the height of the maxillary mucobuccal fold, posterior to the apices of your maxillary second molar, as well as distal to the zygomatic process. So, like I said, when you're taking your pinky back here, you're gonna feel it really sink in. You can do this on yourself outside of class with your slobber all over everything, but you can feel it on yourself. Okay, you're gonna run your finger up in the vestibule, and it's gonna just fall into like a manhole. That's exactly what we're talking about. The mucogingival junction can be seen as a dividing zone between the keratinized attached gingiva and the non-keratinized alveolar mucosa, and thus between the masticatory and lining mucosa. So we're talking about your mucogingival junction, just where the two different tissues meet. You get more into this next semester in histology. It's a sharply defined scallop junction between the pinker attached gingiva and the redder alveolar mucosa. So this is really nicely demarcated on this patient. A lot of times it's not this easy to see. Okay, you just kind of have an imaginary squiggly line, basically. Patient may have exostosis or extra bone on the outside with a buccal aspect of the maxilla or even mandible. Okay, present on the facial surface of either arch on your posterior sextans, which can be hard to really identify the two different tissue types. Okay, also if a patient is a smoker, it's really hard to identify the tissue type sometimes. The needle is inserted within the height of the maxillary mucobuccal fold in a distal and medial direction superior to the tooth apices without contacting the maxilla in order to reduce trauma. And then the injection is administered. So basically, you're targeting up in the fold, again, where I said you can feel it really dip down. If you are feeling it really hard to go in, you may end up being into the attached gingiva or the tissue up here that's on the bone. We don't want to be in there. We want to be more out into the vestibule. Okay, we're not going to be out into the cheek. It's too far. So right where the tissue kind of folds like this. Okay, you're going to be right up in the fold. This will be a little bit kind of what a cadaver is going to kind of look like for you guys when you do that workshop. This is a nice little image to kind of show you exactly where that's targeting. Okay, this will be it for your PSA. Kind of shows you different areas too, but I just want to show you this one. The correct needle and syringe barrel angulation to the injection site must be maintained throughout using 3 different orientations, but only one movement. The angulation should be superiorly at 45 degrees to the maxillary occlusal plane, and medially at 45 angles to the maxillary occlusal plane, posteriorly at 45, so remember 45. It's a long axis. So basically, you don't want to come straight up, and you don't want to come straight back. You need to be at a 45-degree angle as you go in. When you're doing your PSA. As you can see on this image, we have arteries and veins as well as nerves. There's going to be your yellow, arteries and veins are red and blue. Okay, you see how closely intertwined all that is? And we need to stay away from it. It's very easy to actually get into those blood vessels versus getting into the nerve. That's why you got to make sure that you do your aspirations. Maxilla should not be contacted at any time during the PSA injection. If bone is contacted immediately after the needle penetrates the soft tissue, the medial angulation of the syringe barrel towards the maxillary occlusal plane, more than 45 degrees, is too great. So basically, if you're running into bone, you need to come out and readjust yourself, is what this is saying. Serious complication can occur if the needle is advanced too deep into the tissue during a PSA block. The needle may pierce the deeper pterygoid plexus of veins and the maxillary artery if over-inserted. So we have different length needles. Some of you have already been in dentistry, you already know this. We have longer needles, we have shorter needles, we have itty bitty ones. Okay. You never want to use a needle that's too long in the site, whether you're seasoned at doing injections or you're not. Okay, because you can run into a problem of going too far. Well, let's say even the patient jumps and you went too far as you were administering, and now you're into this plexus of veins, which then is a whole other slew of problems. And you don't really want to be into a plexus of vein. You're not going to get into the cavernous sinus, but the cavernous sinus, remember, is another plexus of veins. What happens in a plexus of veins? A lot of blood is going through there, and now you just administered local anesthesia into the blood system. Okay. What happens when we have anesthesia entered into the blood system?
So.
What?
Hematoma.
You can have hematoma, which is like a bruise. Yep. But the patient starts getting jittery. The heart starts racing. They start feeling that they're having an anxiety attack. Those that have never experienced that before don't know what's happening, and then they're freaking out. And they think that there's a medical emergency happening. Okay. And sometimes it's the end of that. You can't do any treatment. Okay. So, extraoral hematoma, as Mahmoud said. This results in a bluish, reddish extraoral swelling of hemorrhaging blood in the tissue with the infratemporal fossa on the affected side of the face, a few minutes after the injection, progressing over time inferiorly and anteriorly towards the lower anterior region of the cheek, ending in an extraoral hematoma. So basically, you end up with a bruise on the inside of the mouth. You'll end up with swelling as well. It's like a chipmunk on one side. Over time, that bruise is going to be moving down. Okay, as the swelling kind of comes down, it is a really dark lesion on the outside of your face that will move down forward. When we were doing continuing education courses for local anesthesia, we have pictures, which you guys will see, of a student who had this, and she took pictures every day of where it went. It was migrating down. It was pretty big. We had a student that had the same thing as he was going through his. So that's really important. I'm paying attention to where you're injecting. It's going to happen. It can happen, you know, but just making sure that you're paying attention to what you're doing. Studies are now being completed that are showing that past depths of injection may have been somewhat deep in the quest to reach successful anesthesia. The initial research shows that less depth with a conservative insertion technique may be just as effective because the space fills easily with the agent and is less risky overall. So again, try to do something that's a little bit more conservative. The less amount of drug administration that you can use for the greatest effect, also the less amount of depth that you penetrate for the greatest effect. Okay, and that's just understanding your armamentarium, which I've always just that word, I don't know why I always call it. Armamentarium is like all the things you need for local anesthesia. So make sure that you're choosing the right anesthetic agent, make sure you're choosing the right needle size, make sure you're choosing the right needle length. Okay, for where you're going and what you're doing.
How do you determine the needle length?
Needle length depends on which injections you're doing. You'll learn that, but like your inferior alveolar nerve is gonna be your long length. Your PSA is gonna be your short. You'll learn that. So that'll be this time next year. I know. Welcome to hygiene school. Your MSA or your MSA block anesthetizes your maxillary premolars and possibly the mesiobuccal root of your maxillary first molar, as well as the associated buccal, periodontium, and gingiva within one maxillary quadrant. So again, these are bilateral. So you have to anesthetize one side and then the other to get the whole top. Okay. Typically though, when you're doing anesthesia, like I said, on a patient, let's say you're doing deep cleanings or what we call SRPs, you're going to stick to one side and not be bounced around all over. If the patient doesn't need any anesthetic, you can do all areas. Okay. I've done the whole right side and then the top on the left if I had time. You know, that way when they come back for a shorter appointment, I just have enough left to do. Every person is different, but typically in offices, you'll stick to one side and then come back and do the other side again. Like I said, never, ever, ever do both lowers at the same time. To ensure complete maxillary quadrant anesthesia, most clinicians administer this block even though the MSA may not be present. When the MSA nerve is absent, as occurs in 72% of the cases, the region is innervated by the PSA and the ASA. If anesthesia is associated with a palatal, periodontium, and gingiva of these teeth is necessary, you may need to do a greater palatine or your GP. The target area for your MSA block is the middle superior alveolar nerve, if present, as part of the superior dental plexus that is located to the superior, located superior to the apex of your maxillary second premolar. So, as you can see, the needle is not going completely straight up. It's kind of going at an angle, okay? So your injection site is literally going to be between the two premolars. That's where your target site is going to be, okay? That's going to get your, and get your two premolars. It's going to get your mesiobuccal root, okay? It's also going to get the tissue. When you're looking here, this is what you're targeting. Okay. See the branches coming over here. Okay, so you're targeting these branches of your MSA. The injection site is within the height of the maxillary mucobuccal fold, superior to the apex of your maxillary second premolar. The needle is inserted within the height of that mucobuccal fold until its tip is located superior to the apex of your maxillary second premolar without contacting the bone, okay, reducing trauma. So, as you're going in to this area, it's important to say the patient has exostosis and you have to work around it. You can't have your needle coming up straight because now you have a bulk of bone here. So you kind of have to activate your needle in a different fashion and a different angle. So again, critically thinking, I can't just go straight. I'm going to smack into the bone. It's going to do nothing for the patient. First one's going to hit bone. Okay. So you've got to kind of think about these things. And again, in the fold of the tissue, where the tissue is kind of in the vestibule, okay, that's where you're targeting. You want to have a steady hand as well. Again, no shaking. You're probably going to be shaking because you're nervous. For the first while, okay, that's fine, but I'm talking about a little shaking. Shaking of the cheek or shaking of the lip. We're not doing any of that. A lot of times you can stabilize yourself, like I'll have, like, so they've got their fingers pinching here. I'll have another finger to stabilize here, or I'll stabilize myself on my finger rest or the patient's lip, it just depends. Sometimes patients have Parkinson's or, we have a lot of old people here in Florida, Sunshine State, retirement state. You're gonna be shaky, they're gonna be shaky. So you just gotta try to keep as steady as you can and go with their shake sometimes, or just try to stay as steady as you can. And it gets a little bit tricky sometimes when they're really shaky. But try to stay as stable as you can. Sometimes you have a stabilizer and sometimes you don't. Yes, you have to watch out for frenum or frena attachments. So insert the needle more posterior with your MSA block to avoid going through the frenum. You do not want to have your needle go through that frenal attachment. That will not feel so good. In some cases, adjustment can be made by retracting it more anteriorly, making sure to leave at least 5 to 10 millimeters on each side of the frenum. So basically what that's saying is if I pull the cheek out, and let's say I'm like kind of pulled out like at an angle like this, my frenum are coming this way and it's right in my way of where I need to do my injection. If I move that tissue forward as I'm pulling it out, it'll come out of the way a lot of times. If it doesn't, just go just distal to it. Okay, you don't want to anesthetize into the frenum. Okay. So your ASA anesthetizes the anterior superior alveolar nerve and thus anesthetizes the maxillary anterior teeth and associated labial periodontium and gingiva to the midline within one maxillary quadrant. So again, your ASA is going to do one side or the other. So you're going to have your right ASA or your left ASA. Okay. That's going to do your teeth, labial mucosa. It's not going to take care of the lingual or your palatal aspect here. That's going to be your NP. Okay, so you have one here and one here. Communication occurs between the MSA and both the ASA and PSAs as part of your superior dental plexus. Some clinicians could consider the ASA block to be only supraperiosteal injection, but because it has a larger area of anesthesia and the local anesthesia agent is deposited near the larger nerve trunk of the ASA, and considered a nerve block. So basically we call it a nerve block. Okay. Again, the ASA can also involve crossover innervation to the contralateral side in the patient. This may need to be taken into account when using local anesthesia in this area. Crossover innervation is the overlap of the terminal nerve fibers on the contralateral side. Bilateral injections of your ASA block or infiltration to the apex and contralateral maxillary central incisor may be indicated to complete the anterior sextant if the patient is still feeling discomfort during treatment. So let's say I'm working on the right-hand side of my maxilla. I've done my PSA, I've done my MSA now, I've done my ASA, and I get to the mesial of number 8, and they're still really feeling it, and they can't deal with me for another few minutes. Okay, so then I could do my ASA on this side, or I could infiltrate that 1 tooth. Okay, either way, depending on what I'm doing. If I'm going to be doing this quadrant anyway, I might as well just do the ASA, right? Target area for your ASA is the anterior superior alveolar nerve as part of your superior dental plexus. That's superior to the apex of your maxillary canine. So for your target area here, what we try to target is between the lateral and the canine, that you get in the correct space. Okay, it's also kind of directly underneath the nostril. When you do this injection, a lot of times it burns in the nose. This is not the most fun injection. I don't know if anybody in here has had it, but you will feel a burning sensation in your nose. Patient is going to want to hold the breath. That's what we do when something hurts. But the more you hold your breath, the more that it hurts. So you tell your patients to breathe. So you're keeping your eyes on a couple things, right? So you're keeping your eyes on where you're injecting. You're also going to be keeping an eye on your barrel to see how much you're injecting, your syringe, okay? But you also need to keep part of your eye on that patient's stomach and making sure they're actually breathing. You're reminding them to breathe. You need to talk to them. Breathe, deep, slow breaths. You know, they go like this or they hold their breath, it hurts more. It actually makes the neurons affect the area worse. Don't ask me how, it just does. So it actually can be more comfortable if they try to breathe a little bit. So talking to your patients sometimes in a nice calm voice really helps them to relax versus saying nothing at all. Okay, so trying to remind them to breathe is big. Because also you don't want to end up with patient passing out when you're trying to do local anesthesia. A lot of times with that one, they're trying to run away from you, right? It hurts. They're trying to go this way, they jump, but you gotta stay steady and go with them. There they go. Okay, so the injection site is within the height of the maxillary mucobuccal fold, superior to the apex of your maxillary canine. Again, when you look here, kind of targeting, you're going between the lateral and the canine to actually access the apex area. So you're kind of in parallel with that canine eminence. The needle is angled at approximately 10 degrees off an imaginary line. Everything's imaginary in this world with this. Down the parallel to the long axis of the maxillary canine. The needle is inserted within the height of the maxillary mucobuccal fold until its tip is superior to the apex of your canine without contacting the maxilla. So again, if the patient has exostosis there or extra bone, you got to critically think to get around it, right? Also for any freeing. Your infraorbital block or your IO anesthetize the infraorbital nerve and also both the anterior superior alveolar and your MSA to cover the regions of both of those in one injection. We do not teach you this. Okay, so I'm not going to go over this.
Do we have to not worry about it?
No. Not for me. When you take your local anesthesia boards, probably. But we'll worry about that time. We're not anesthetizing. So that's what I said, you can accidentally anesthetize if you go too far. So this is a good example. If you're using the wrong size needle, you anesthetize too far, now you've also anesthetized that patient's eyeball. Right? So we're not doing a lot. Now, that would be a good injection for someone probably doing some oral surgery, but not for hygiene. Okay, so our injections are more on the conservative side of what we need strictly for our hygiene visits, not for surgeons and all other business, extractions and whatnot, okay? Anything with the IO, blocks, just skip. All right, greater palatine block for your GP. Anesthetizes the greater palatine nerve and thus anesthetizes the posterior heart palate and associated palatal periodontium and gingiva. On the ipsilateral maxillary posterior teeth, within the maxillary posterior sextant, not a quadrant, sextant. What's a sextant? Remember? So how many sextants do you have? 6. Okay. So be on your posterior teeth. Right, so sextant here, and then this would be a sextant, and then this would be a sextant. Down here, this is a sextant, this is a sextant, this is a sextant. Because the GP block does not provide anesthesia of the pulp or associated facial periodontium and gingiva of the area teeth, you also need to administer MSA and PSA. We're not doing IO. In addition, anesthesia of the associated palatal periodontium and gingiva of your maxillary first premolar may prove inadequate because of the overlapping nerve fibers from the anteriorly located nasopalatine nerve. This lack of anesthesia may be corrected by additional administration of your nasopalatine block or your NP. So this is basically saying that they use pressure anesthesia over the depression of the greater palatine foramen. So we use that Q-tip to apply the pressure. We don't use a topical anesthetic. This pressure is going to cause a dull ache that blocks the pain impulses that comes from the needle insertion and local anesthetic agent. When you go into these areas on the palate, there's not much room for you to go because there's a bone there, right? Not very far. That tissue is pretty thin. When you're going into a foramen, it's a little bit different. Okay, you do, if you're in the right spot, you have access to kind of go a little bit farther. You'll feel it sink in. Okay, but utilizing this pressure, the pressure is uncomfortable, but it does take the discomfort away from the actual injection itself. You would rather feel the discomfort from the Q-tip than you would the knee. The target area for the GP block is greater palatine nerve entering the greater palatine foramen. I talked about all these. So anatomy of the palate can include a midline palatal torus and or high vaulted palate. A high vaulted palate means the palate is pretty deep and narrow, okay? So when we have palatal torus, that can get in the way of where we would do our injections. Excuse me, okay? Same thing with a high vaulted palate. Okay, so you guys kind of have to change your approach a little bit. For palatal injections, I could say I've probably only done a handful since I've been doing local anesthesia since 2013. Typically patients are okay without it, and I always give them the option unless I absolutely need it and to access. If I can't access, then I'll just go ahead and do it. But if I think that they can tolerate, I'll give them the option. Most people are going to opt out and they'll just toughen it up. And they're fine. The greater palatine foramen is noted as a depression on the palatal surface, usually at the junction of the alveolar process of your maxilla and posterior hard palate, as well as superior to the apices of your maxillary second or third molar, which is approximately 10 millimeters medial and directly superior to the palatal gingival margin. You will never be giving anesthesia to a child, ever. If someone asks you to do anesthesia on someone below 18, tell them no. Right? It is illegal for us to give anesthesia to anybody that's a minor. Okay? Just know that. The depression can be palpated approximately midway between the median palatine raphe overlying the median palatine suture and the palatal gingival margin of your maxillary molar, starting near the most distal maxillary molar and moving inward. Okay, so again, start like at your first molar and go backwards. As such, this landmark of the greater palatine foramen is where pressure anesthesia is applied throughout the injection. So, as you are applying the pressure, you're going to notice that the tissue around it's getting more white, okay, because you're deflecting that blood from going in there. As you start injecting, you're lifting the pressure of this Q-tip off completely, slowly. Okay, the reason being is if I'm pushing on this and I'm trying to inject into a hole, I'm pushing all that solution out of the hole. So you need to remove the Q-tip and remove the pressure so that solution has somewhere to go. That goes for up here too when you're doing your NP. Site of injection for the GP is the palatal tissue anterior to your greater palatine foramen. Sometimes you'll get the needle bowing, which means it's going to kind of bend a little bit. You just got to be careful with this because you don't want the needle to break off into the patient's mouth. Okay. A little bit of bowing is fine. The needle is advanced until the palatine bone is gently contacted and then injection is administered. All right, your NP, your nasopalatine block, anesthetizes the anterior hard palate and the associated palatal periodontium and gingiva for your maxillary anterior teeth bilaterally from canine to canine. So your NP going from canine to canine on your lingual aspect, palatal aspect. So just that anterior sextant. So both the right and left nasopalatine nerves are anesthetized by this one block. So you get both sides. You get the right and the left of the lingual on those anteriors. The NP does not anesthetize the pulp or associated facial periodontium, an area of the teeth. So additional anesthesia by your ASA or MSA, not your IO, may be needed. Anesthesia of the associated palatal periodontium and gingiva of your maxillary canines may prove inadequate because of the overlapping nerve fibers, which is then when you do your GP. Again, using pressure anesthesia as we talked about. The target area for your NP is both the right and left nasopalatine nerves entering the incisive foramen of your maxilla. Okay, so your target spot is going to be your incisive foramen, just underneath your incisive papilla. So you're gonna apply your pressure sensitivity here, waiting for that tissue to blanch or turn white. Okay, you need to be pretty firm with it. Okay, and then you're gonna anesthetize just lateral to it. Right here. As you're anesthetizing and pushing the solution in, you're lifting the Q-tip off. So you're not pushing the solution out. Again, you can have the vaulted palate or your palatal torus that can be in the way of doing some of your palatal injections. So you just gotta be careful and critically think about getting around it. Typically it doesn't really bother when you're doing your NP. Okay, just more of your GP. We don't teach you this one, so that's why we're going over it. Correct. So we don't teach you the last one, so do excel those two. Some of this I'm gonna go fly through because a lot of review, we're running out of time. And we've already run over today. So part 2, your mandibular nerve and its branches can be anesthetized in a number of ways depending on the tissues and structures needing anesthesia, okay? Your supraperiosteal injection of the mandible is not as clinically effective as it is on the maxilla because the bone density is different. Okay, remember how I said it's easier to get numb on the maxilla than it is on the mandible. The anterior trunk of your mandibular nerve or anterior division of your mandibular nerve is formed by the merger of your buccal nerve and additional muscular nerve branches. Your posterior trunk or posterior division of your mandibular nerve is formed by the merger of the auriculotemporal, lingual, and inferior alveolar nerves. Your inferior alveolar block or your IA block is also known as your mandibular block and is most commonly used injection in dentistry. It anesthetizes the mandibular teeth to the midline and associated lingual periodontium and gingiva to the midline, as well as the associated facial periodontium and gingiva of the mandibular anterior teeth and premolars to the midline within one quadrant. So basically, a whole quadrant. Just remember that. So that, therefore, the IA blocks the inferior alveolar nerve and the lingual nerve. Not all of the branches of the mandibular nerve are anesthetized with the IA and is not considered a true mandibular block. So you have to do IA and long bubble for the whole block. Additional use of buccal block may be indicated if anesthesia of the associated buccal periodontium and gingiva of the mandibular molars is also necessary to complete the mandibular quadrant anesthesia. You will almost always be doing an IA along with a buccal. Okay, I can't tell you that I have ever done just an IA or just a buccal. Okay, because typically when you're doing scaling, you're going to be just doing scaling all the way around the tooth, and you need buccal and lingual. Okay. Target area for the IA block is the inferior alveolar nerve exiting the mandibular foramen on the medial surface of your mandibular ramus, overhung anteriorly by your lingula. If you remember what that is, it's on more of the medial aspect here of your ramus. The adjacent, more superficial lingual nerve will also be anesthetized as the local anesthesia agent diffuses. So there is no need for injection of a separate injection for this nerve. So we're not teaching you how to do a lingual nerve. Just know that that lingual nerve will be anesthetized when you do your IA. The injection site for your IA is within the depth of the pterygomandibular space, demarcated by the pterygotemporal depression on your medial border of your mandibular ramus at the correct height determined by when you find your coronoid notch and you're running, I don't know why they're using the finger, but you run your thumb outward so that you can actually get a good retraction. If you don't put your thumb all the way back here at the coronoid notch, you're going to have all this meat of your cheek in your way. And then you're going to probably end up going through with your needle in through the cheek, which you don't want to do. So you want to have really good retraction and make sure you're taking that thumb all the way to the back of that coronoid notch and going laterally with it so that you can have a clear vision. Pterygomandibular space is a small fascial lined cleft containing mostly loose connective tissue. This space is bordered by the medial pterygoid muscle and the medial medial surface of your mandibular ramus. You can go through this muscle when you're doing your anesthesia. You're going to feel like you've hit bone, but it might be just a little bit bouncy. That's the muscle. You can push through it. The patient will feel it, and they will be sore. It happens. A lot of stuff in there. Stuff in your way. I'd rather you go through a muscle than a blood vessel. Posteriorly, the parotid salivary gland curves medially around at the border of the mandibular ramus, where anteriorly the buccinator and superior constrictor muscles come together to form a tendinous band, your pterygomandibular raphe. You're looking for that pterygomandibular raphe when you're doing this injection. Intraorally, it's noted as a pterygomandibular fold because it stretches to become accentuated as the patient opens comfortably wider, which is important instruction to relate to the patient when administering this block. You want them to open wide so that that band stretches so that you can see where that is, because it's going to be a landmark for you to be able to identify when you're doing the anesthesia. It's important. It extends from behind the most distal mandibular molar with the retromolar pad and runs somewhat horizontally to the posterior border of the mandibular ramus as it turns superiorly at the junction of the hard and soft palates, separating the buccal mucosa of the pharynx. So if you go back to this, okay, you're looking at this pterygomandibular fold. Okay, if the patient doesn't open, this tissue here is loosey-goosey and you won't see it. Okay, they need to open wide.
So what if they have a TMJ issue and they can't open wide? What do you do?
Well, I go off the field. So the pterygotemporal depression is the hollow between the medial pterygoid muscle and the laterally located tendon of the temporalis muscle, hence its name. Okay. This depression exists between the pterygomandibular fold and the coronoid notch. It serves as a visible landmark for needle entry into the depth of the pterygomandibular space for the injection. So you'll kind of see a little depression here. You'll see what looks like a little bit of an imaginary triangle when you get into each. Have you guys gotten into each other's mouths yet? I don't think you have yet, right? No. Okay. But you'll start to see these items that we're talking about. Okay. The height of the injection for the IA block is determined by the palpating the coronoid notch, the greatest depression on the anterior border of the mandibular ramus. So again, you take your thumb at that coronoid notch and you move it laterally. Okay, the height of your thumb is going to be your injection site to determine the actual injection height. Okay. So the pterygotemporal depression demarcating needle entry for the inferior alveolar block into the depth of the pterygomandibular space usually mimics an inverted teardrop or by some thought to be a triangular shape. And this, like I said, will make more sense when you guys get more intraorally. But when you have the proper retraction, you're going to see what kind of looks like a teardrop or what I usually see as a triangle in that area. You'll know exactly where, you'll be able to feel it. When you take your Q-tip, like they were doing, you take your Q-tip because you're going to target, it's going to really sink in there. And that's your target spot. Okay. The specific injection site for needle entry into the depth of the pterygomandibular space is within the depression's superior basin-like part or nearer to its posterior position base of the triangle. Okay, you see how like that's really sinking in right there? You're really gonna get in. Indications for a clinically effective IA block include harmless numbness and tingling of the lower lip to the midline because the mental nerve, a branch of the inferior alveolar nerve, is anesthetized. This is a good indication that the inferior alveolar nerve has been initially anesthetized, but is not a reliable indicator of the depth of anesthesia, especially concerning pulpal anesthesia, which is why I said to check your patients with an instrument prior to starting. Because just because they'll have some tingling on their chin doesn't mean that they're numb. If they have tingling, it's working. Okay, just like when you have tingling several hours later, that means it's wearing off. You may experience a lingual shock as the needle passes by the lingual nerve that may occur during administration. The patient may make an involuntary movement varying from a slight opening of the eyes to jumping up in the chair. This reaction is only momentary and anesthesia will quickly occur. I worked with a doctor who always had lingual shock on their patients because he felt it. Not that it's wrong, you're in the right spot, just sometimes that happens. Even though the IA block is most commonly used dental injections, not always initially clinically effective. The level for a lack of clinical effectiveness is approximately 15 to 20%. This may mean that the patient must be re-injected to achieve the necessary anesthesia of the tissue. However, the careful clinician will use a troubleshooting injection paradigm in order to achieve clinical effectiveness every time the IA block is used. So if you went in to do an IA and they didn't get anesthetized, you're gonna go in the exact same spot? Maybe not, right? So you need to critically think about where you were at. Maybe you were too anterior, you need to be more posterior, maybe you were too inferior, okay? Readjust yourself, take a look at where you were, okay, because you'll be able to see it in the tissue. And sometimes they don't need to have topical again, you can just go in and do the injection because the tissue should be already numb, because it has the agent in it. It's just the actual nerve itself. The soft tissue should be fine. To further complicate matters, not many patients are symmetric in their anatomic positioning of related mandibular structures. So the IA block can be different on each side of the patient's oral cavity. You might have one that's super high on the right-hand side and one that's more inferior on the on the left. Okay, they're not always symmetrical. Documenting these anatomic variations as well as any technique adjustments that were implemented on the patient's chart will assist the clinician during subsequent appointments, whether it be you or it be somebody else. Like if they have a high IA block, just to write that in the chart, high, aim high. No, different things like that, any little tidbits, because you're not going to remember 2 years down the road, you're not going to remember and you have to do it again. If bone is contacted immediately after the needle is inserted into the soft tissue, when trying to administer an IA block, it's possible that the insertion point was too inferior and or too far lateral from the pterygomandibular fold, overlapping the raphe. So you want to leave the needle tip in there a little bit. You're not going to completely bring the needle out, but you leave the needle in just a hair, and then you adjust yourself to get it to the right spot. So you withdraw the needle by having the syringe barrel more anterior or closely superior to the mandibular anterior teeth when it's reinserted. Okay, so again, you don't want to take it all the way out of the tissue because then you're going to have multiple penetration marks on the patient's tissue and it's more uncomfortable. You just slightly withdraw it and then you move it a little bit. If bone is not contacted when trying to administer the IA, even with the correct depth of insertion by the needle tip is located too far posterior on the medial surface of the mandibular ramus. This is a horrid image to see. You never want to not see any of your needle here. Okay, that is way too far in. Okay, you're gonna do some damage. Not to mention the barcode's in the way here. You can't even see how much you've administered. Seems terrible. None of you are gonna be doing that. The needle tip may enter the medial pterygoid muscle and be medial to the sphenomandibular ligament instead of lateral to it. Again, withdraw a little bit and then change where you're at. So if the insertion and deposition of the material are too shallow and bone is not contacted, but the local anesthesia agent is administered, the medially located sphenomandibular ligament can become an outer physical barrier. This ligament can prevent the agent coming into contact with the deeper mandibular foramen and inferior alveolar nerve, thus preventing the more profound pulpal anesthesia, which is why the patient would still feel things. Okay. Also, if you go too far within the medial pterygoid muscle, the patient is going to have trismus. So not to be able to open their mouth very wide, and it's going to be very painful, especially when the anesthesia wears off. Okay. It's important at times not to deposit local anesthesia agent if bone is not contacted on insertion of the needle for an IA block. The needle tip may be too posterior and thus rest within the parotid salivary gland, carrying the facial or seventh cranial nerve, resulting in serious complications.
So you're always gonna hit the bone?
You want to hit the bone. That's where your nerve's coming out. You want to have contact with the bone. One complication with IA is transient facial paralysis, like we talked about before, where involving that facial nerve. Okay, because it runs through your parotid salivary gland. Did contact bone, you just went through that. If there's still lack of clinical effectiveness, it's mainly noted on the mandibular first molar. Even after proceeding with the troubleshooting injection, there may be accessory innervation present for this tooth. We don't do mylohyoid injections, so I'm not going to go over that. We don't do that injection on the lingual. Sometimes teeth can have an anatomic anomaly and have bifid, meaning two inferior alveolar nerves. So to work with this anatomic anomaly, the local anesthesia agent is deposited more inferiorly to the usual anatomic landmarks for the targeted area of your IA or your Gaugate's mandibular block. So this is nice when you have like a panoramic view of a patient. You can really see kind of where those nerves are or how high that foramen might be on that person. If you try to get them numb and you're like, this isn't working, you want to pull up that panoramic view and see, do I need to go higher? Do I need to go lower or what? Okay. So as you can see here, this is the bifid canal. They have one here, okay, their mandibular canal. Again, you can have paresthesia if you have a trauma from your IA, if you anesthetize a lingual nerve, which would be burning or prickling, feeling like pins and needles feeling. A hematoma can occur with the IA because the injection has the highest positive aspiration rate of all block injections. Again, an aspiration rate is when you get blood in your cartridge. So, patient self-inflicted trauma. Patients need to understand that when they get a lower anterior, or excuse me, a lower block, that their lip is numb. They can bite themselves, their tongue is numb. They can bite themselves, they can burn themselves and not know it till that anesthesia wears off. This is a kid that ended up biting his lip that was numb because he was probably trying to chew something, or sometimes we have a habit of, he might have bit too hard because he couldn't tell how much he was biting. Your buccal block or long buccal block anesthetizes the buccal nerve and the associated buccal periodontium and gingiva of your mandibular molars within one quadrant. The target area for your long buccal is the buccal nerve on the anterior border of the mandibular ramus in the area of the retromolar pad overlying the retromolar triangles. So you want to stay parallel to your occlusal plane, just distal to that last molar. You're not going to get in very far here, and this one does pinch because you don't have much space before you contact it all. The injection site is the buccal mucosa that is distal and buccal to the most distal mandibular molar. The syringe barrel is parallel and directly superior to the mandibular occlusal plane on the side of the injection. So again, stay parallel with the occlusal plane. You don't want to be, your occlusal plane is here. You don't want to be coming out here because now you're going to be going where? Out towards the cheek. You got to stay parallel with the occlusal plane, okay? As you're going in. And it's literally just distal to that last cusp of your last molar here, right in here. Again, you're not getting in very far. And sometimes you'll even see some of the solution coming out. It's just not enough room. The needle's advanced till it gently contacts the mandible, and then the injection is administered. Patient can bite their cheek and not know it until the anesthesia wears off. This kid must have been chewing some food. He wasn't supposed to be chewing. Ended up biting himself pretty good. You always want to tell them not to eat anything that's hot, not to eat anything that you got to chew until the anesthesia wears off. The mental block anesthetizes the mental nerve and thus the associated facial periodontium and gingiva of your mandibular anterior teeth and premolars to the midline within one quadrant. If pulpal anesthesia is necessary on your mandibular anterior teeth and premolars, you might want to do the IA. Does not provide any anesthesia to the lingual aspect. The target area for the mental block is the mental nerve entering the mental foramen. This block catches the mental nerve before it merges with the incisive nerve. So usually you would start your penetration, your needle penetration at your canine, and then kind of dragging it to your foramen, your mental foramen. After you do this injection, you would hold pressure to help that solution go into that foramen. You don't ever want to rub because you're just dispersing the solution elsewhere, but you're trying to help it go into that hole and not go everywhere else. To locate the mental foramen, for the incisive block, palpate first the depth of the mandibular mucobuccal fold, inferior to the apices of your mandibular first molar and moving inferiorly to the apex of your mandibular canine, or in a site indicated by a radiograph until a depression is felt. Look at your x-rays. Typically between your premolars, closest to your second premolar. The injection site for the mental block is anterior to the mental foramen on the lateral surface of the mandible within the depth of the mandibular mucobuccal fold. So the needle is advanced without contacting the mandible, and then the injection is administered. The incisive block anesthetizes the mental and incisive nerves, and thus the mandibular anterior teeth and premolars, as well as the associated facial periodontium and gingiva to the midline within one quadrant. If you need anesthesia on the lingual aspect, it's saying to do the IA. Incisive block is also used when there's a crossover innervation from the contralateral side. The target area for your incisive block is the incisive nerve within the mental foramen. This block catches the incisive nerve as it merges with the mental nerve. We already talked about how to locate it in the injection. More local anesthetic agent is deposited within the tissue for the incisive block than for the mental block. And the pressure is applied to the injection site after the injection to enhance agent diffusion. This pressure forces the more of the agent into the mental foramen, anesthetizing the first shallow mental nerve and then the deeper incisive nerves. So they're showing you pressing intraorally. We always show you to press extraorally, have the patient close, they can relax, and you just keep your hand there outside their face. I can teach you that, we don't learn that. A lot of that I skipped over because, like I said, we don't teach those here. A lot of that you will learn this time next year. So like I said, for your exam, I want you to understand, obviously, what nerves are what. You know the Roman numerals, you know which ones they are, right? What it's going to anesthetize. Is it sensory or is it motor or is it both? Afferent or efferent, right? Take a look at the color chart, that will really help you. Take a look at that other page that I showed you that had some study tips on it. Okay, and then break your studies up. So the trigeminal and the facial have a lot of stuff involved with it. So maybe get down your other nerves, maybe get down the order first, right? And then study the other nerves of what they do, and then study the two big ones on their own, right? Do the trigeminal one and then do the facial. Okay, that might help to kind of get that down. As far as I'll post a Kahoot for you guys so that you guys can do that at home. Okay, as far as that goes, and any questions? Feel free to message.
Since we covered a lot, is it gonna reflect in the number of questions that we are?
Yeah, but again, it's not gonna be more than 60 questions because we only have an hour. You have more than an hour. Okay. What?
I said same thing.
Yes, yes.
Same process.
Oh,